Dear colleagues, welcome to the fourth annual OncoAlert Colloquium, presented by the OncoAlert Network and our esteemed partners at the American Society for Radiation Oncology, the European Society of Surgical Oncology, the European Society of Gynecological Oncology, MASC, the International Association of Supportive Care in Cancer, SIOG, the International Society of Geriatric Oncology, and the OncoAlert Consortium, which is made up of 12 medical oncology societies from low and middle income countries. Today, we bring you the top of 2023 in GI oncology with an amazing lineup and a very complete wrap-up in surgical GI oncology. Our presenters are Dr. Cathy Eng, colorectal cancer and anal cancer, Dr. Sharlene Gill, gastric, esophageal, and liver cancer, Dr. Mark Lewis, pancreatic cancer, Dr. Ben Westphallen, controversies in GI cancer, Dr. Eric Miller, GI radiation oncology in the ASTRO session, Ms. Allison Rosen, the patient advocate perspective. We then move on to surgical oncology in the ESSO sessions. Presenters are Dr. Giovanni De Manzoni, gastric surgery, Dr. Maria Bencivenga, colorectal surgery, Dr. Salvatore Paiella, pancreatic surgery, Dr. Simone Conci, Hepato-Biliary surgery. We hope that you enjoy this day 4 in GI oncology. And now, without further delay, Dr. Eng.
My name is Dr. Cathy Eng, and it's my pleasure to present on behalf of OncoAlert the year in review for colorectal cancer and anal carcinoma. I'm at Vanderbilt Ingram Cancer Center here in Nashville, Tennessee. So we're going to be focusing on the MSI-high metastatic colorectal cancer patient population first. If you recall, pembrolizumab was approved based upon the KEYNOTE-177 study when compared to standard chemotherapy in the treatment-naive MSI-high metastatic colorectal carcinoma patient, looking at dual primary endpoints of PFS and OS. And what they noted is that in comparison to the chemotherapy arm, there was improved PFS at 12 months as well as at 36 months. Please note there was some crossover of the KM curves for PFS early on, suggesting there was benefit for chemotherapy. It was more favorable at first. However, the eventual results showed that the display is very clear in favor of pembrolizumab. For overall survival, the hazard ratio was 0.74. And please keep in mind there was crossover allowed for those patients in the control arm. Now, at this year's ASCO GI Symposium, we had the information from Checkmate 8HW, which is nivolumab versus nivolumab ipilimumab versus chemotherapy versus nivolumab, as a single agent. And the primary endpoint here is progression-free survival. Now, we only have the information of the combination versus chemotherapy at this time, and it was a 2:2:1 randomization. These are the demographics. They're very comparable with both arms. As you can see here, there were more patients that discontinued due to treatment progression on the chemotherapy arm. And here are the results thus far. We do not have any more information at this time. There is early on display of the KM curves for PFS at approximately 3 months, 79% 12-month PFS, and 72% 24-month PFS. So more data to follow, and I look forward to looking at the comparison versus the nivolumab arm. These were the toxicities. None were unexpected. And so once again, we look forward to more information. Let's focus on the KRAS G12C patient population. So we saw at this year's, last year's ESMO meeting, sotorasib plus panitumumab at 2 different doses versus the standard of care. And this is a phase 3 CodeBreak 300 study. Here you can see the reason. I think we are well aware that sotorasib by itself is not as effective, but better in combination based upon the earlier phase 1, phase 2 trials that was completed before. Here is the study design, 2 different doses in a 1:1:1 randomization. Patients were allowed to have at least 1 prior line of therapy, 960 milligrams versus 240 milligrams versus investigator's choice of trifluridine tipiracil or TAS-102 or regorafenib. Please keep in mind, this is before the Sunlight data came out. PFS was the primary endpoint. And here you can see the demographics. The majority of patients had received at least 2 prior lines of therapy. sorry. And here are the results of the PFS, 5.6 months versus 3.9 months for the higher dose of 960. The PFS for across all subgroups was in favor for the combination, and the response rate was higher at 26% versus 6% versus 0%. This is the overall survival, hazard ratio of 0.77 in favor of the 960 dosing. But the data is not mature. Please keep that in mind for OS at this time. Now, let's talk about patients with liver metastasis. This is the CAIRO-5 study, and this was presented at ESMO last year as well, and I thought this was interesting. For surgically unresectable disease, comparing right-sided versus left-sided tumors, you can see these are the standard combinations for right-sided tumors, standard combinations for left-sided tumors, excluding the fact they do not have a FOLFOXIRI bevacizumab arm. And as you can see here, for the right-sided tumors, improved response rate with FOLFOXIRI plus bevacizumab, as well as improved PFS, but no difference in overall survival, which was presented at this last ESMO meeting, which I think is important. No statistical difference. For the left-sided tumors, improvement appeared to be for the PMAM combination with chemotherapy of FOLFOX or FOLFIRI, but the overall survival also was not statistically significant. Therefore, it suggests that for right-sided tumors, there's no difference between the combinations provided in regards to overall survival. The same for left-sided tumors in regards to overall survival. Please keeping in mind there it was not a FOLFOXIRI plus bevacizumab arm. What about just general metastatic colorectal cancer? Well, we had the data from LEAP-017 presented at ESMO, World GI ESMO Congress meeting, which unfortunately was a negative study in regards to improvement of overall survival for lenvatinib with pembrolizumab in the refractory colorectal carcinoma setting. But we have also learned that Sunlight, which was presented at ASCO GI a year ago, has since been approved. And this is specifically in the third line setting, looking at TAS-102 plus bevacizumab versus TAS-102 alone. Primary endpoint here is overall survival, and this was a global study, once again, in the third line setting. Please keep in mind that about 28% of patients did not receive bevacizumab in the investigational arm. The overall survival here was 10.8 months versus 7.5 months, hazard ratio of 0.61 in favor of TAS-102 plus bevacizumab. And this validates the prior phase 2 trial that had been completed. We have also learned that we have positive results from FRESCO-2, which was presented at ESMO in 2022, but it has since received FDA approval, and that's why I'm presenting it here in this set. So it's a 2-to-1 randomization in the refractory patient population. Patients were allowed to receive TAS-102 and or regorafenib, so they did not have to be exposed to both. Patients were randomized in a 2-to-1 fashion, and the primary endpoint was overall survival. This is an oral tyrosine kinase inhibitor, specifically of VEGF receptors 1, 2, and 3. Here are the demographics, median of 4 prior lines of therapy. Most patients, at least half, had received prior TAS-102. About less than 10% received regorafenib alone, and about 40% in both arms had received both drugs previously. The primary endpoint was met with an improvement in overall survival with a hazard ratio of 0.66, so 7.4 months versus 4.8 months. Oh, please keep in mind it's a median of 4 prior lines of therapy. This needs to be corrected, which was in the prior demographic table. As such, the FDA has approved fruquintinib based upon not only this phase 3 trial, but the other phase 3 trial that was already conducted in China, specifically in the third line setting. And because of the 2 pooled analyses of FRESCO and FRESCO-2, the FDA has approved fruquintinib in the third line setting plus. Primary toxicities experienced for this class of drugs is not unexpected, primarily hypertension, some hand-foot skin reaction, but overall, the majority of patients did not discontinue therapy as a result of a dose reduction or complete discontinuation due to any of these toxicities. There's also a pending result from fruquintinib in combination with tislelizumab. This trial completed enrollment very quickly, and we are looking forward to the final results. I want you to be aware in the metastatic setting, there are other trials that are ongoing, specifically focused on patients with liver metastasis. This is the Erasure study that is being supported by the Alliance looking at newly diagnosed limited colorectal carcinoma patients and the role of standard chemotherapy versus SBRT plus or minus ablation, plus or minus surgical resection in combination with standard chemotherapy. This is currently enrolling. The primary endpoint is overall survival. There is also the pump trial, which is looking at the role of hepatic arterial infusion pump in patients that have received at least some prior systemic chemotherapy. They may have received up to 12 cycles or up to 8 cycles, depending upon the regimen provided. Once again, this has also just really just opened up and is open for enrollment. And this is the primary endpoint is overall survival. Stellar 303 is currently still open. This is looking at XL092, so a tyrosine kinase inhibitor in combination with atezolizumab versus regorafenib as the standard of care. And the primary endpoint here is overall survival in the refractory patient population. What about the role of circulating tumor DNA? There were several studies looking at the role of circulating tumor DNA, so I just want to highlight some specific trials. One being Circulate Japan, because of the size of the study. This is why I'm highlighting this in particular. Greater than 5,700 patients were enrolled. They ended up with a little less than 3,000 patients with stage 1 through 4 disease with circulating tumor DNA after surgical resection that was available. MRD window was considered 2 weeks post-op, up to 10 weeks post-op, looking at the role of adjuvant chemotherapy once again, and it appeared to be predictive of inferior disease-free survival if the circulating tumor DNA is positive. As you can see here, look at the disease-free survival at 24 months. Large difference if you remain negative versus if you became positive. What about disease-free survival according to the MRD window, specifically in stages 2 and 3? Same findings hold true, as you can see here, a large difference for this patient population. Looking at also sustained clearance versus transient clearance of circulating tumor DNA versus no clearance, you can see a large difference here, once again, of disease-free survival based upon your circulating tumor DNA, whether it was transient versus sustained versus no clearance at all. They also looked at the impact of circulating tumor DNA and clearance with the role of adjuvant chemotherapy at 6 months. And as you can see here, if it cleared with the use of adjuvant chemotherapy, once again, improved DFS. And also, same findings hold true during the surveillance period. If you remained negative throughout the surveillance period versus becoming positive at any point, large difference in DFS as well. I did want to highlight the COBRA study, which was a large phase 2, proposed phase 3 study looking at the role of circulating tumor DNA and clearance of circulating tumor DNA in the stage 2 setting. This is the study design, as you can see here. Arm 1 was standard of care. Arm 2 was looking at the consideration of utilizing circulating tumor DNA to make decisions regarding chemotherapy. So if it was positive, you received 6 months of treatment, and if it was negative, you were placed on surveillance. And this was presented by Dr. Van Morris just recently at ASTRO GI. These are the time points that the circulating tumor DNA is collected. And you can see it is collected right before the last dose rather than following the completion of the treatment as well. They utilized the Guardant Lunar assay, which was available at that time when the study was originally designed. And that was the best study design that the investigator, as well as the NCI, felt was appropriate for this study. And once again, the primary endpoint was circulating tumor DNA clearance. And as you can see here, what they noted was, in fact, there was increased clearance, ironically, in the surveillance arm versus the chemotherapy arm. And this exceeded the 0.35 null hypothesis. And as a result, the trial was stopped due to early futility. Now, what is the reason for this? Well, as you can see, it depends upon what time points you collect. This is a very nice presentation and discussion for Dr. Parikh at ASCO GI. Obviously, it depends upon how often you collect your time points of circulating tumor DNA. And please note that this was not a tumor-informed circulating tumor DNA. They used the Guardant panel, which was a tumor-uninformed circulating tumor DNA. It's looking at a panel that's already preconceived. And here you can see the technology changed during the time that the study was open to enrollment, which can obviously impact how an outcome of a clinical trial. So I think it basically demonstrates the challenges of creating a clinical trial design while technology is developing and is ongoing in refining its capabilities. I want to remind you, Circulate US for stage 3 patients is still open. We encourage you to enroll to this clinical trial. This is utilizing a tumor-informed assay with the Signatera platform. I do find this interesting. People are always worried about the impact of circulating tumor DNA on patients' anxiety and will it help. The bespoke data was presented at this year's ASTRO GI, but the numbers were much smaller, and that's why I chose to discuss the Circulate Japan. Galaxy Japan study results. But here you can see 73% of patients reported reduced anxiety when they had this study completed. They felt they were receiving the right treatment following the results. 92% would continue utilizing circulating tumor DNA, and 96% valued the additional information provided by circulating tumor DNA. What about rectal cancer? Well, I want to touch upon the Prospect trial. Many of you are aware this was a trial that was completed many years ago looking to mid to high-lying tumors. So those tumors greater than 5 centimeters above the anal verge, did not allow T4 tumors, and it did not allow N2 tumors. Patients were allowed to receive 6 cycles of FOLFOX but before being assessed for response. And this allowed the opportunity to omit radiation therapy for locally advanced rectal carcinoma patients. If there was greater than 20% response, patients proceeded onto surgical resection. And please keep in mind, this study design did not consider watch and wait approach at that time. These are the results. No difference in disease-free survival, freedom from recurrence, or overall survival with long-term follow-up, a median of follow-up of 58 months. Please note once again, though, it did not include T4 or N2 tumors and did not include watch and wait approach. In Europe, this trial has completed enrollment. This is the AIO study looking at the role of short course radiation therapy versus long course radiation therapy, followed by chemotherapy, primary endpoint being sphincter preservation. This is the ongoing Janus trial, which we encourage you to enroll to for patients with locally advanced rectal cancer. Updates in anal carcinoma. Not much is going on at this time because we still have several trials that are currently pending results. EA2165 has completed enrollment, and we are waiting for those results looking at the role of immune checkpoint inhibition in high-risk patients, so those patients following chemoradiation therapy with tumors originally greater than 4 centimeters or with node-positive disease. We also have heard at this year's ASCO GI the results of basically enzabenlimab, which is immune checkpoint inhibition in combination with DCF therapy, induction DCF in combination, and then to proceed on to chemoradiation therapy. And basically, this was presented as a poster at this year's ASCO GI, noting a fairly high complete response. But once again, for early stage disease, we do expect a significant response capabilities with concurrent chemoradiation therapy, which is the standard of care for early stage anal carcinoma. But please note there were some significant toxicities. One patient died after developing capillary leak syndrome, and one other patient died fairly soon due to progression of disease. And there were some associated grade 4 toxicities. Once again, this is a phase 2 single arm study. Radiance is ongoing in Europe, and we look forward to seeing those results once it's completed enrollment. EA2182 is still enrolling. There's a few spots left for T1, T2, and 0 tumors, looking at reduction of mitomycin dosing, leaving it at 10 milligrams per meter squared for week 1 only, and as well as reducing the dose of radiation therapy in the investigational arm. 2-year disease control rate is the primary endpoint. NCI 9673 has been presented at last year's World GI Congress, noting that for nivolumab versus nivolumab plus ipilimumab in previously treated metastatic squamous cell carcinoma patients, primary endpoint being progression-free survival. Unfortunately, no difference in progression-free survival for the combination versus single-arm nivolumab. No difference statistically of response rate as well as disease control rate. But obviously there were some patients that fared extremely well, but not statistically different between the 2 arms. OS also, although it seemed to be in favor of the combination, not statistically different. And more toxicities were seen with pneumonitis in the combination arm. So at this time, nivolumab or single agent immune checkpoint inhibition remains the standard of care in the refractory setting. I wanted you to be aware there is still an ongoing trial for treatment-naive patients, largely going on in Europe, which involves retifanlimab in combination with carboplatin and paclitaxel. Primary endpoint, progression-free survival. This is a 1-to-1 randomization, largely being conducted in Europe and the UK. Here in the United States, we have carboplatin plus paclitaxel plus or minus nivolumab based upon our earlier work. And here we do allow HIV-positive patients as well. And also it involves correlatives, including HPV circulating tumor DNA. This is a 2-to-1 randomization, which is different from the European study or UK study, which was a 1-to-1 randomization. And please enroll to this clinical trial. It is also nearly complete in regards to enrollment, but it does afford an amazing opportunity for patients, given that this is the first NCI phase 3 clinical trial that has been conducted in the metastatic treatment-naive patient population. And we are always looking for new approaches to address this disease. So I'd like to thank you all for your attention and thank you for your time today in learning more about how to treat colorectal carcinoma and anal carcinoma.
Hi, my name is Sharlene Gill. I'm a GI medical oncologist based out of BC Cancer in Vancouver, Canada, and really delighted to receive the invitation from OncoAlert to participate in this colloquium. I'm going to be speaking about updates in gastric, esophageal, and liver cancers, and these are my disclosures. So I'm going to start with advanced esophagogastric cancers. If we think about sort of the landscape of a metastatic disease, there have been, a number of years where we failed to see demonstrable advances in the treatment of advanced esophagogastric cancer, where the median survival has typically hovered at less than a year, with the exception of the introduction of trastuzumab for HER2-positive disease in 2009 following the TOGA trial. We know that changed in the recent era within the last few years with the opportunity to use immunotherapy, PD-1 inhibition in combination with frontline platinum and 5-FU-based chemotherapy in HER2-negative advanced esophagogastric cancers, driven primarily from data from 4 pivotal trials. And so just to summarize those trials, which has been previously presented at this colloquium, but Checkmate 649 was a trial of chemotherapy, FOLFOX/CAPOX plus nivolumab in esophageal GE junction and gastric adenocarcinoma, so an all adenocarcinoma trial. Checkmate 648 was a study of chemotherapy plus nivolumab in esophageal squamous cell cancers. The Keynote trials with pembrolizumab looked at these combinations in a fairly similar fashion. So Keynote 859, which was more recently presented, was chemotherapy plus pembrolizumab, again in that adenocarcinoma GE junction gastric population. And Keynote 590, which is presented earlier, was chemo plus pembrolizumab in esophageal GE junction adenos and esophageal squamous. So the majority of patients in Keynote 590 had esophageal squamous cell cancer. So I'm going to just at a very high level remind you of sort of the data from these pivotal trials. So Checkmate 649 was chemotherapy, oxaliplatin 5-FU-based chemotherapy, plus or minus nivolumab. That was the main question. And the main population of interest, although it was an all-comers trial, were those patients whose tumors had a PD-L1 combined positive score or CPS score greater than 5, looking at the primary endpoints of overall survival and progression-free survival. About 60% of patients had a PD-L1 CPS score greater than 5. This was a global study, including an Asian population. And 60% of patients had de novo metastatic disease. And we're talking about the study because it was positive. It met its primary endpoint for progression-free survival and overall survival in the PD-L1 CPS greater than 5 enriched population. So in that population, overall survival delta as a median was greater than 3 months with a hazard ratio of 0.7. And in fact, when you look at all comers in that population, a statistically significant survival benefit was still observed. The hazard ratio is now attenuated a bit to 0.79, with a median survival improvement of over 2 months. Recognizing that, that benefit is still likely driven by sort of the PD-L1 CPS enriched population. Keynote 859, which was presented more recently, was the pembrolizumab study in a similar population histology-wise, GE junction gastric adenocarcinoma, and it was, again, chemo plus or minus pembrolizumab with a primary endpoint of overall survival. Again, in HER2 negative patients. Most of the patients received CAPOX as the chemotherapy backbone. Again, also a global study. The PD-L1 sort of threshold, I think that was pre-identified, was a CPS score greater than 1, and 80% of patients had tumors with a PD-L1 CPS score greater than 1. This trial met its survival endpoint for overall survival in all comers, and in those patients with a PD-L1 CPS score greater than 1, a hazard ratio of 0.74, over 2-month improvement in overall survival. And if we look at patients with a PD-L1 CPS greater than 10, that was about half the patients, hazard ratio is now, more meaningful in this enriched population, 0.69, with a 4-month improvement in median overall survival. Switching gears to kind of the esophageal population, if you will, Checkmate 648 was the study that looked at the use of nivolumab plus cisplatin 5-FU chemotherapy in esophageal squamous cell cancers. Primary endpoints, again, were overall survival and progression-free survival. And in this study, in terms of trying to look at PD-L1 expression, a tumor positive score, tumor PD-L1 score was the assay that was chosen with a threshold of greater than 1%. And so approximately 50% of the patients had tumors that were PD-L1 greater than 1%, and 60% had de novo disease. So in 648, a significant benefit was seen with the addition of nivolumab to cisplatin 5-FU chemotherapy in esophageal squamous cell cancers. If we look at the all randomized population, it has a ratio of 0.8. And in those with tumor PD-L1 greater than 1%, you really see a meaningful benefit. The median overall survival is improved by 6 months, a hazard ratio of 0.59. And again, that was about half the patients. And then a Keynote 590, which was the study, again, including patients predominantly with esophageal squamous cell cancers, but did also include esophageal and GE junction adenos, Keynote 590, with chemotherapy plus or minus pembrolizumab. Again, also demonstrated a overall survival and progression-free survival benefit with the addition of pembrolizumab to chemotherapy in this population. And if we focus on the patients with squamous cell cancers, benefit was clearly seen. And in those who had squamous cell cancers and a PD-L1 CPS greater than 10, the hazard ratio for benefit was 0.59. And so these trials really have changed the landscape in terms of the availability of PD-1 inhibitors or immunotherapy in combination with chemotherapy for patients with advanced esophageal gastric cancers. And as a consequence of this data, of this level 1 evidence, guidelines have been updated to reflect this change in first-line therapy. So both the ASCO guidelines, which were updated last year, and the ESMO guidelines, which have also been recently updated, reflect the role of immunotherapy in combination with chemotherapy in HER2 negative disease. One of the questions that remains, of course, is what is the role of the biomarker PD-L1 CPS? And what is clearly seen is a signal for enrichment. And if this is a algorithm from the ASCO guidelines from January 2023, which divides patients, the assessment by HER2 status. So in patients with HER2 negative disease, and then the next column divides it by anatomic subtype. And then the third column divides by PD-L1 CPS score. And what we see is that for patients who have a PD-L1 CPS of 0, which is about maybe 15% of patients, the ASTRO guidelines recommend chemotherapy alone, reflecting sort of an increased understanding that these patients are really unlikely to benefit from the addition of immunotherapy. And then beyond that, really, which threshold, I think there's a lot of variability, in that. But certainly for those patients who have a tumor PD-L1 CPS score that's greater than 5, I think that would reflect patients in which we really should be considering immunotherapy unless there is a contraindication for immunotherapy. Moving to the HER2 positive space, and this is more recent data that was presented at ESMO just last year. Keynote 811 looked at patients with HER2 positive disease and the benefit of pembrolizumab in combination with FOLFOX or CAPOX chemotherapy and trastuzumab as the standard of care. Again, with dual primary endpoints of overall survival and progression-free survival. And when this data was presented by Dr. Janjigian last year, we learned that this was, again, a global study. A third of patients were from Asia. PD-L1 CPS score was assessed, and 85% of patients, again, were PD-L1 CPS positive, greater than 1. And this was a HER2 positive patient population. Again, over 82% were HER2 3+, and CAPOX was the preferred regimen in 85% of patients. The progression-free survival, as presented at ESMO, it met its primary endpoint for improvement in progression-free survival in all patients, hazard ratio of 0.73, somewhat more significant in those patients, those 85% of patients that had a tumor CPS greater than 1. The overall survival endpoint was met in the subgroup of patients with a PD-L1 CPS greater than 1, hazard ratio of 0.81, and an over 4-month improvement in overall survival, median overall survival, but it statistically did not meet the signal for overall survival in all comers. So that survival benefit was only seen in patients with a PD-L1 CPS greater than 1. In terms of response rates, a really notable increment in response rates with the addition of pembrolizumab to chemotrastuzumab in this patient population. And you'll recall that it was this interim data that led to the initial approval or access to this therapy in the US for patients with HER2 positive disease. And now we have sort of the progression-free survival data to support that. The question about the fact that the survival benefit was limited to those patients with PD-L1 CPS had become a very germane issue. And in fact, from Keynote 811, there's a suggestion that for those 15% of patients who were PD-L1 CPS 0, right, less than 1, that there was indeed no signal of benefit with the addition of pembrolizumab. And in fact, perhaps a suggestion of a detriment or harm. So if you look at this survival curve, again, it's a small number of patients, some concern that there may actually be a negative effect of the addition of immunotherapy in these patients. So as a consequence, the FDA has amended their label for the use of pembro in HER2 positive disease for patients who have a PD-L1 CPS score greater than 1. And the ESMO Living Guidelines, following the release of this data, were also amended to limit the use of the addition of pembrolizumab to HER2 positive standard care chemo plus trastuzumab for those majority of patients with a PD-L1 CPS greater than 1. Thinking a bit about sort of other targets in HER2 negative, I think one that was discussed a lot last year was Claudin 18.2. So Claudin 18.2 is a tight junction protein that's normally expressed in gastric mucosal cells. And zolbetuximab is a first-in-class chimeric IgG1 monoclonal antibody that targets Claudin 18.2. It also induces antibody-direct cellular cytotoxicity. In the phase 2 phase 2 trial presented 2 years ago of the FAST-2 study, the use of zolbetuximab in combination with triplet chemotherapy was associated with improvement in progression-free survival and overall survival, and that led to the confirmatory phase 3 trials. So the 2 trials that were presented last year were Spotlight, which was also published in Lancet, which was FOLFOX chemotherapy plus or minus zolbetuximab in HER2 negative Claudin 18.2 positive disease. And based on the FAST-2 phase 2 trial, Claudin positivity was defined as those patients with greater than 75% staining of Claudin 18.2 in tumor cells. So placebo-controlled trial with a primary endpoint of progression-free survival. And if that met its primary endpoint, there was a planned analysis of overall survival. Approximately 38% of patients who were screened tested positive for Claudin 18.2. So kind of gives you a sense of the prevalence of Claudin 18.2 in this HER2 negative population. Most of these patients were patients who had gastric cancer. About 22% had GE junction cancers. And in an ad hoc, so kind of not planned analysis, about 13% of these patients also happen to be high expressors of PD-L1 CPS, defined as a CPS score greater than 5. Spotlight met its primary endpoint for progression-free survival, hazard ratio of 0.75, favoring the addition of zolbetuximab. And you kind of see a sort of sustained separation of those curves over time. Subsequently, overall survival was also analyzed and positive for statistically significant improvement in overall survival with a hazard ratio of 0.75. And if you look at the 3-year kind of landmark overall survival rate, doubling of 3-year overall survival, 21% versus 9%. In terms of the toxicity profile, most of the toxicities in comparison to placebo and chemotherapy were fairly comparable in terms of myelosuppression, but zolbetuximab was definitely associated with an increased risk of nausea and vomiting, and that was typically seen most commonly in the first cycle, and then would drop off quickly with subsequent cycles. Lots of discussion around why that may be. There was some hesitation to use corticosteroids with the first infusion, and perhaps that may have increased the risk of nausea. And also remember that zolbetuximab does have a loading dose with that first cycle, so perhaps also increasing the risk of nausea, kind of felt potentially, I guess, to be an on-target effect of Claudin 18.2, which is primarily in the gastric mucosa. That being said, I think it's kind of recognized that we need to think about this regimen as a highly emetogenic regimen and treat it accordingly in terms of antiemetic prophylaxis. GLOW was kind of almost the confirmatory phase 3 trial, if you will, but with CAPOX as the backbone. So CAPOX plus or minus zolbetuximab. In this study, the screening rate was about a 30% pickup for Claudin 18.2 positivity. And speaking earlier about that co-enrichment for PD-L1 CPS greater than 5, about 20% of patients had a PD-L1 CPS greater than 5. GLOW also met its progression-free survival endpoint, sort of a 0.7, in this case a 0.68 hazard ratio, and overall survival hazard ratio of 0.77, a statistically significant improvement in overall survival. And if you look at the 2-year survival rate, 29% versus 13%. So certainly it's exciting to have these options available, potentially more actionable targets in esophageal gastric adenocarcinomas. Some question about, this small population of patients who may HER2 negative, Claudin 18.2 and PD-L1 CPS positive. And there is an ongoing phase 2 trial called the ASTRO trial, which is a multi-cohort study, but it does include the use of potentially immunotherapy in combination with FOLFOX and zolbetuximab. And really, the story doesn't end there. In esophageal gastric cancers, it's difficult to cover it all in a short period of time, but we also know coming likely soon in terms of potential change in practice are the use of trastuzumab deruxtecan or TDXT, the antibody drug conjugate in patients with HER2 positive disease previously treated with trastuzumab, really promising data from the Destiny gastric studies, and bemarituzumab, which is an FGFR2b targeted antibody, which has been in the FIGHT study shown to demonstrate a really encouraging efficacy. And now there's ongoing, the phase 3 Fortitude trials are looking at the use of bemarituzumab in combination with chemotherapy in those patients whose tumors express FGFR2b. So I think the future really indeed is bright for esophageal gastric cancers. And I think we're kind of, looking forward to sort of staying in tune with how these will update our potential treatment landscape for patients with HER2 negative disease. Moving on briefly to discuss hepatocellular carcinomas, the ASTRO guidelines were updated a few years ago, kind of reflecting a current standard of practice for patients with advanced, typically BCLC stage C, hepatocellular carcinoma with adequate hepatic reserve, Child-Pugh A, reflecting a standard of care of first-line atezolizumab and bevacizumab based on the IMbrave 150 trial, with the option of lenvatinib for patients who may be ineligible for immunotherapy or for whom atezo-bev may not be the preferred consideration. And then really thinking about sort of a sequential approach for post-progression therapies. And that, for those of us who've been treating HCC for a few decades now, really the landscape has remarkably evolved over the last few years. In terms of recent data, I think last year we heard the data from the RTOG 112 NRG study, which looked at the potential use of SBRT in combination with systemic therapy, in this case, sorafenib, in patients with locally advanced hepatocellular carcinoma, Child-Pugh A. And this was a positive trial for overall survival for the addition of SBRT to sorafenib. Sorafenib is no longer a standard of care in terms of systemic therapy, but I think it really has opened up the spectrum for the opportunity to add SBRT to systemic therapy in advanced HCC with a possible endpoint of improving overall survival. And when we think about sort of the evolution of trials, phase 3 trials in advanced hepatocellular carcinoma, I think the earlier studies really reflect kind of what is the current sort of standard of care in terms of options for lenvatinib or atezo-bev. And more recently, we've had data with Himalaya, now with the STRIDE regimen, a non-bev containing regimen of durva-tremi, a single priming dose of tremi, demonstrating a survival benefit over TKI therapy from the Himalaya trial. And interesting data from camrelizumab and rivocerimab, again, sort of looking at a VEGF IO type approach in combination with sorafenib. Interestingly, LEAP-002, which was the trial looking at lenva-pembro, was not positive, but it's important to recognize that the control arm was lenvatinib, and lenvatinib remarkably had an overall survival of 19 months in that trial. So, really, if we kind of look at how the Barcelona Clinic liver cancer staging and treatment algorithm has evolved, we really see this, increase in options for first-line systemic therapy, but also a recognition of the opportunity for systemic therapy in earlier lines, particularly in intermediate stage disease. So I'm going to close just with a quick update on data that was just presented at GI ASCO, the EMERALD-1 study, which was a study in intermediate stage HCC, looking at the role of immunotherapy in combination with TACE. So these were patients who were randomized in a 1:1:1 fashion to 3 arms of TACE plus durva, followed by continued durva, TACE plus durva, followed by durva-bev, or the standard of care arm, which was TACE alone. And the primary endpoint was progression-free survival, primarily comparing durva-bevacizumab plus TACE versus TACE alone. And the trial met its progression-free survival endpoint with a hazard ratio of 0.77 for superiority of the addition of durva and bev to TACE. But durva plus TACE alone was not superior. Durva plus TACE, was not superior to TACE alone. So, really kind of reminding us that synergy with the VEGF really does seem to be important in this space. And so while the primary endpoint was met, I think the overall survival data is still awaited, and PFS may be a potential surrogate in this space, but I think many of us would be keen to hear the overall survival data. And also there are trials forthcoming looking at IO and TACE combinations as well, including LEAP-012, which will also help kind of inform what the utility of immunotherapy may be in combination with TACE for patients with intermediate stage HCC. So thank you very much for your attention. It was really a pleasure for me to provide this update, and I hope you enjoy the rest of the colloquium. Thank you.
Hello, OncoAlert. My name is Mark Lewis. I am a gastrointestinal oncologist, and I'm the director of GI Oncology at Intermountain Health, based in Salt Lake City, Utah. But for the purposes of this presentation, I think what's most important is I am a member of the OncoAlert Consortium and a proud participant in this year's colloquium. And again, a big thanks to Gill Morgan for his organization, his leadership, and his true democratization of knowledge. To any of you that are watching this that practice general oncology, I applaud you for your breadth. I do realize I'm enormously privileged in my current post to have depth and even to attend subspecialty conferences. So for instance, I'm recording this relatively soon after ASTRO GI this year. And what I want to tell you about today is what I'm excited about in the field of pancreatic cancer, where we've been, where we are, and where I think we are going. So without further ado, let me advance my slides here. So our agenda, I want to talk about resectability and what those criteria look like. I want to talk about PREOPANC 1 as a lead into PREOPANC 2. I want to talk about the GENERATE trial. I want to talk about KRAS as a legitimate target in pancreatic ductal adenocarcinoma. And because I am something of a neuroendocrine tumor maven, being a NET patient myself, I would be remiss not to at least touch briefly on pancreatic neuroendocrine tumors, because again, the pancreas is not just about adenocarcinoma, but understandably that gets a lot of our attention, given that it remains one of our most lethal solid tumors. So I have to be honest, as a medical oncologist, I know not quite what I say when I talk about resectability. Now you'll notice I have a 3D model here. This is what I use in my own clinic, my own medical oncology clinic, to try to explain to patients the incredibly intricate relationship between their primary pancreatic tumor and the peripancreatic vasculature, the arteries and the veins. However, I think this is a very sanitized, almost idealized anatomy. I'm not the one in the operating room that is having to tease apart this sometimes very tenuous interface between the tumor and those crucial blood vessels. I'm not the one that's having to deal with peritoneal stroma and desmoplasia that makes resectability so much more complicated for our surgeons. So I'm starting with this table and graphic because I myself am constantly revisiting resectability criteria, and I actually use the graphic there on the right, which is taken from a fantastic JAMA review written by the Sloan Kettering Pancreas Group, to try to show patients the difference between abutment and encasement. And I really think that, if you're dealing with venous and arterial encasement, that's one way of thinking about locally advanced pancreatic cancer. If you're talking about venous encasement with arterial abutment, you're probably getting closer to borderline resectable. And as we all know, there's some very specific criteria related to the degrees of contact between the tumor and the vessels at play. And again, we'll come to that actually with the inclusion criteria for one of the studies I'm going to discuss, but just to kind of start our conversation here. So this whole notion of borderline resectable being sort of firmly distinct from locally advanced pancreas cancer has actually been called into question by surgeons themselves. So this was a fascinating article that caught my eye last year. I thought a very provocative question right there in the title: are these really two different entities? And again, surgical oncologists looked at this. And what I thought was interesting is they decided to follow the same NCCN criteria I just showed you. And as you can see, when you follow survival over time from surgery, really, this was not a wonderful way to distinguish outcome. What mattered a lot, perhaps unsurprisingly, and you can say this is all freighted with bias, is whether or not the patients actually got an operation. So rather than falling into the locally advanced versus borderline resectable camp, what ultimately mattered, and again, I don't think we should be too surprised by this, was were the patients operable or not? And so the conclusions from the surgeons, which I found really fascinating as a medical oncologist, they said surgical resection is the only predictor of survival in patients with borderline resectable and locally advanced pancreatic ductal adenocarcinoma, regardless of their initial classification. And I'm bringing this up because I think this can actually cut two ways. I think it speaks against an attitude of therapeutic nihilism for the locally advanced patients. And again, it says, our results suggest that surgery should not be denied to patients with locally advanced PDAC a priori. On the other hand, I don't think we should underestimate the threat of borderline resectable disease. And what I'm really getting at with all this is, well, what is the sequence, especially the multidisciplinary sequence in which we should approach pancreatic ductal adenocarcinoma? So there's a little bit of a hint in the ESMO guidelines. Again, the ESMO guidelines here are a trifurcation for non-metastatic pancreatic ductal adenocarcinoma between resectable, borderline resectable, and locally advanced. And what I think is interesting but might change over time is the recommendation here to do surgery first if it's clearly resectable. And the reason I say that, showing my bias, is some of you will know I had a Whipple operation myself in 2017, again, not for adenocarcinoma, for neuroendocrine tumor. And I was never going to have to do adjuvant therapy. And it's just as well that that was the case, because when I got to the 2-month mark post-operatively, I remember thinking, sort of wearing both hats, I remember thinking as a patient, there is absolutely no way that I could tolerate adjuvant chemotherapy right now, even if it were warranted in my case. And I think we see that actually in a lot of these surgical studies. We see large numbers of patients, maybe in this particular scenario, somewhere between a third and a half, not recovering in a timely enough fashion to initiate adjuvant therapy, which is a huge problem for what is essentially a systemic disease that is only cured in the operating room. And I know that sounds like a contradiction in terms, but that is the way I think of pancreatic ductal adenocarcinoma in all but its very earliest stages. And by that, I mean stage 1A, maybe only. So I think over time, we may come to revisit the leftmost side of this trifurcation. So how did we get to Preo-Panc 2? Well, we only get there through Preo-Panc 1. So this is a fantastic sort of past as prologue trial from our colleagues in the Netherlands who were curious about what I just said. So in the setting of upfront resectable pancreatic ductal adenocarcinoma, is it appropriate to do an upfront operation than with adjuvant gemcitabine? Or is it better in Preo-Panc 1 schema to do what I call the chemo radiation chemo sandwich, again with gemcitabine here, then surgery, and then more adjuvant gemcitabine on the other side? Now, this was a fascinating trial when it was first presented. I think I saw these data at the 2021 ASTRO annual meeting, because it showed that actually you're taking fewer patients to the operating room with that latter sort of experimental strategy. So fewer people are getting resected. However, the R0 rate, so obviously now you've selected down a specific group in the chemoradiation induction patients, the R0 rate was 72% for people that got upfront chemoradiation and 43% for people who got upfront surgery. You'll also note there was an extremely high rate of nodal clearance. So N0 status was more than 3-fold higher in the chemoradiation group than it was in the upfront surgery group, and we'll come back to that. So this is what the overall survival looked like. There was a modest advantage in terms of median overall survival to the patients that got neoadjuvant chemoradiation. But at the 5-year mark, that long tail, again, not as high as we would like, but that long tail had a full 1/5 of patients who had neoadjuvant chemoradiation surviving, which I think is, again, for this particularly deadly disease, pretty remarkable. And you can see there that there's an even greater split if you select out the patients that underwent resection, which again, I think speaks for itself. There, those patients, there was a third of them surviving at 5 years if they did upfront chemoradiation followed by resection. So again, there was a hint here from Preo-Panc 1 that doing something before you get to the operating room was appropriate. Now, critics of the study pointed out that the control arm here, if you will, with surgery first, didn't perform as well as you might expect from historical controls and specifically some adjuvant trials. And there was some concern that maybe the patients that they'd selected for the surgery first arm, when you do an adjuvant trial, you actually get to pick, if you will, patients with better biology who aren't censored for very, very early recurrence, also people that recover quickly enough to do adjuvant chemo. So keep that in mind. And again, that was all sort of in the background of PREOPANC 2. So this is PREOPANC 2. Here, again, also our Dutch colleagues ran a nationwide trial in Holland. Here, they deliberately picked patients who were borderline resectable. And you can see back to those vessel criteria. So fewer than 270 degrees of venous contact and fewer than 90 degrees of arterial contact. It was a 1-to-1 randomization to essentially what they called a total neoadjuvant approach with 8 cycles of FOLFIRINOX before surgery, or, which will look very familiar to you, the chemoradiation sandwich with gemcitabine from PREOPANC 1. So I think that the sort of top line news here is there really was no significant difference. A lot of people had thought, maybe hoped, that one of these strategies would declare itself as the better way forward, and that, as you can see, was not the case. You really can't comfortably fit a laser pointer between these curves, and to me, none of the sort of important endpoints as they relate to longevity are distinct here. However, there were some differences in pathology. So as I mentioned earlier, I think there's a hint, even from PREOPANC 1, that radiation can really affect in-field nodal clearance. So you'll note here a higher rate of YPN0 in the GEM chemoradiation arm. You also note that the R0 rate was slightly, but not statistically significantly higher in the GEM chemorads arm. And then interestingly, complete path response was seen more often, but again, not significantly more often in the FOLFIRINOX arm. So that ends up being a bit of a wash. What I think is important to note, though, is toxicity. So again, the last thing we want to be doing is rendering patients frailer before a major life-changing operation. Again, one that I consider myself lucky to have survived. So here you can see a slightly higher rate of serious adverse events in the FOLFIRINOX arm. Diarrhea in particular was significantly more common in the FOLFIRINOX arm, as was febrile neutropenia. And I think our understanding of what to do in these cases also remains borderline, if you'll forgive the wordplay. So again, this was a trial now several years back, conceived by Matt Katz at MD Anderson. This is Alliance 021501, trying to answer the question, should we do 8 cycles of FOLFIRINOX pre-op, or should we do 7 followed by radiation? And again, Matt very nicely illustrated, I think, the way this can look radiographically leading into the operating room, giving the surgeons some sense of the difficulty they're going to have teasing the tumor apart from the peripancreatic vessels. This trial, rather famously, some might say disappointingly, did not show an efficacy advantage for FOLFIRINOX followed by radiation. You can see there that actually, in terms of 18-month overall survival rates, it was higher with FOLFIRINOX. So again, this trial did not answer the question, neither did PREOPANC 2, about should we be doing all chemotherapy before surgery? Is it more appropriate to do a chemoradiation chemo sandwich before surgery? But what I keep coming back to is, in my heart of hearts, I'm more inclined to think about doing something, specifically something systemic pre-op, because I think one of the worst things we can do to these patients is operate on them with a life-changing surgery like the Whipple, and then see metastases blossom, sometimes even while they're still recovering from the operation. I think we know then, with sort of bitter hindsight, that those patients should never have seen the operating room in the first place. However, to finally muddy the waters before we move onward from this section, this was a real-world experience from Roswell Park presented just at ASCO GI this year, showing that actually in their cohort, in patients who had resectable pancreas cancer, upfront surgery was associated with the longest overall survival. Now, what's fascinating when you dig into this abstract and poster is the role of CA 19-9. So for all of our fancy tests, and even our evaluation of radiographic tumor vessel interface, it turns out the CA19-9 might be a true trifurcator. So what they found here is that patients who had CA19-9s whose median was under 100, they actually definitely fared the best with doing upfront surgery. The patients who did neoadjuvant intent chemo and then went on to surgery, they tended to have their first or baseline CA19-9 in this sort of low 100 range. And then the median CA19-9 for patients who got chemo first and never saw the operating room, that was actually closer to 500. So I think there's something to be said for the CA19-9 and how it guides our hand and what we should do first. Remembering, of course, the CA19-9 can also be artifactually elevated by the insertion of biliary stents. Remember, that perturbs the duct and that raises your marker, even if it's not indicative of true tumor biology. Finally, in the very bottom left of this particular graphic, I want you to see that of the 54 patients who went through upfront surgery in the Roswell Park cohort, a full 19 of them, which is almost exactly a third, did not get adjuvant. So again, I want to make the point that doing surgery first may well prevent or preclude you from doing adjuvant chemotherapy at all, and what is almost certainly a systemic illness. So again, we're still figuring our way here. Maybe my final message before we move on from this section is please, please, please have a low threshold for presenting these patients at tumor board. Okay, so moving from the resectable or questionably resectable setting to the clearly inoperable setting, unfortunately that of metastatic disease, either upfront or in the recurrent setting. So this was a Japanese trial, so JCOG 1611 or GENERATE, trying to answer the question, is the nab-paclitaxel gemcitabine doublet, how does it fare up against triplets like modified FOLFIRINOX, and this is a triplet that we couldn't do here in America, but they can do in Japan, S-IROX. So taking S1, the oral fluoropyrimidine available in that country, and pairing it with irinotecan and oxaliplatin. Now, I'll say going into this, I think there was some belief in our community that triplets had to be better than doublets, but I think this trial sort of overturned that conclusion. So let's look at GENERATE survival and response data. Most strikingly, in terms of overall survival, sort of the blue line there is the doublet, and then pink and green are the triplets. And you can see that just barely missing statistical significance in terms of hazard ratio. The median survival of the doublet was longer, on the order of several months, beyond the triplets. In terms of progression-free survival, though, the curves are much more convergent. And then in terms of response, I bring up this graph because this is actually something I talk to my patients about. But buried in here is the metric that I actually highlight for them, and that is disease control rate. I suspect many of us have had the really kind of heartbreaking experience of going into a room, maybe even smiling going into a room, knowing that a patient's scans show response, only for them to tell us that they don't feel any better. And I think that disconnect is because radiographic response by RECIST criteria does not equate to improve quality of life or decrease symptom burden for patients. That's a false equivalence. What I think matters the most, though, when we have liver metastases is, can we maintain stability? So for me, disease control, the sum of response and stable disease, that actually matters. And that's something I can generally explain to patients. Again, they may not feel it. The liver is largely insensate. But I firmly believe that the preservation of the liver parenchyma and function thereof is a key, perhaps even the rate-limiting step in keeping these patients alive. So for me, the disease control rate here, which again was certainly not inferior for the doublet, I think was also a really telling takeaway. But what about toxicity? So again, these are people that we're treating in the palliative setting. It matters a lot, I think, for their quality of life that we not be inflicting too many side effects on them. So interestingly, here the doublet actually, to forgive my phrasing, inflicted more hematologic toxicity, specifically neutropenia or leukopenia, than the triplets. Now, keep in mind, this gem-Abraxane dosing was 3 consecutive weeks and then a 4th week off. Sometimes I'll actually modify that to do day 1, day 15, and allow day 8 for hematopoietic recovery, regardless. Febrile neutropenia, though, was more common with the triplets. And then what I find really telling about this is anorexia was worse with the triplets. And look at the very bottom right. I think this is actually recapitulating a little bit of the Zilleri story. Here in the United States, I very, very seldom combine capecitabine and irinotecan. I just find the diarrhea is pretty horrendous for the US population. I was actually curious to see if our Japanese sort of counterparts would show better tolerance of S1, but it turns out the combination of S1 with, I suspect, irinotecan in particular, caused pretty profound diarrhea. So grade 3 or worse diarrhea in about a quarter of the patients. So I think that is unfortunately a big red flag there. Okay, let's now move to KRAS. I am still of the age where I was taught that KRAS was undruggable. I think that is a paradigm that we are shattering in real time. KRAS G12C, though, has gotten a lot of attention, with sotorasib and with adagrasib and with the trials that have sort of brought those targeted agents to prominence, CodeBreak and Crystal. Here, though, and again, this is very sort of incipient, I'm really excited to see that people are expanding their perspective and their targets to consider KRAS G12D. So you can see there that in terms of the pie chart, the tiny sliver of patients will have KRAS G12C mutations that we can target with either adagrasib or sotorasib. But G12D takes up almost half of that pie chart. And so there's a variety of agents. As you can see, almost all of them are still in the alphabet soup of having experimental letters and numbers assigned to them. But I'm really excited to see where this goes. I'm also kind of amazed that we're at the point where we could potentially vaccinate against KRAS. So again, this is, if I'm honest, some immunology that's sort of beyond my understanding. So if you'll forgive me, I might reference the manuscript here in a second. But this to me is remarkable. So this was a fascinating study published in Nature Medicine last year with Shubham Pant out of MD Anderson as the PI. And really what he and his group were doing here is they took 25 patients, 20 with pancreas cancer, and I think 5 with colorectal cancer. And they used this vaccination strategy in sort of the MRD setting. So they had biomarkers that they could track. They crafted this vaccine, if you will, using KRAS G12D and G12R as these long peptide antigens. They tagged it to an amophile DNA adjuvant, and then they administered it to the patients as a subcutaneous injection. What happened there was this binding to endogenous albumin that got presented to lymph nodes. And then finally, there was delivery to the antigen presenting cells and T cell activation. And there's, again, a lot of really amazing science in this paper. But this really, I think, tells a story of what they were able to view in terms of biomarker response. So by following sort of T cell dynamics here, they were actually able to bifurcate how patients did in terms of survival. So you can see there, the bottom right graph D, the median recurrence-free survival was not reached for patients who were above the median T cell response, whereas unfortunately it was only 4 months for patients who were below that median. Now, we can always talk about these statistical strategies and what we do with continuous variables, but regardless, I think they're really onto something here in terms of this can be an immunogenic cancer, and KRAS can be targetable. And watch this space, because I have a strong sense that that's where a lot of pancreatic cancer research is heading. Finally, like I said, I would be kicking myself if I didn't talk briefly about pancreatic neuroendocrine tumors. So Cabinet was an effort to improve the standard of care for last-line systemic therapy for neuroendocrine tumors. So Jennifer Chan was the PI, and the cohort included both pancreatic and extrapancreatic neuroendocrine tumors. For the purpose of this discussion, I'm going to focus on pancreas. Again, you can see there was a 2-to-1 randomization to cabozantinib at 60 milligrams or placebo. And again, against the placebo arm, the progression-free survival of cabozantinib was more than 3-fold, almost 4-fold, almost got to a year in the cabo arm in a heavily pretreated cohort. So again, I've shown you several different sort of guidelines or algorithms in this talk. These are the ENETS guidelines for several months ago, and I think now they would have to be updated with cabozantinib slotting in here. So for advanced grade 1, grade 2, non-functional pancreatic neuroendocrine tumors, the first bifurcation is the expression of somatostatin receptors or not. Obviously, if you've got that expression, that's targetable with analog and also with PRRT. If you don't, though, you've been left with drugs like everolimus and sunitinib, and then typically an alkylating chemotherapy, like say Captem. For me, I think cabozantinib is still going to occupy the last line that cabinet intended it to occupy. But in this one case, I think it's nice to have another arrow in our quiver. More options is not always better, but for these patients who tend to sort of progress relatively slowly through lines, I think it's always nice to kind of see what might be available for them later on. And then finally, to really upturn the apple cart, I'll point out that NETTER-2 may have changed the way that we sequence PRT for grade 2 neuroendocrine tumors. And again, I won't elaborate on that in this talk, but there's a lot of buzz after ASCO GI about where exactly does PRT fit for well-differentiated grade 2, grade 3 tumors. Should it go first, or should we still treat with analog first? Remembering that PRT is both expensive and has a non-zero risk of iatrogenic harm in the form of treatment-related myelodysplasia and AML. So watch that space as well. So in conclusion, it's an exciting time for pancreatic malignancy research. And most importantly, we are learning things at these conferences and in these papers that we can bring to clinic to make our patients' lives hopefully longer and better. And with that, I thank you so much again, especially to Gill for organizing this, for letting me participate in the colloquium. And I hope you learned from this session. My contact information is there if you have any questions or want to engage in dialogue. I just wish you the best, both during this sort of educational forum and in your larger practice. Take care.
Hi there, my name is Allison Rosen. I'm a colorectal cancer survivor and patient advocate, and I'm going to provide the patient advocate perspective on colorectal cancer updates. There's a lot that's been going on, but before I go into those updates, I want to tell you a little bit about myself. I worked previously in cancer research for a long period of time, about 12 years, in cancer health disparities. And during that time is when I was diagnosed with colorectal cancer at the age of 32. So from cancer researcher, I turned into a cancer patient. Then I became a cancer survivor after going through treatment. I went through chemotherapy, radiation, chemotherapy again, multiple surgeries. And then I became a cancer advocate. And I became an advocate because I really wanted to meet other people like myself. I felt very alone going through treatment. Everyone thought my mom was the patient, but it was me. I was young. I was not what they would call your typical patient, but unfortunately the trends are now younger and younger, which we'll talk about in a second. But by meeting other people and getting involved in cancer advocacy, I really found my second family, people that just understood me. So now I'm an advocate and I do policy research, all sorts of things related to colorectal cancer in adolescent and young adults. Some of the organizations that I volunteer with and I'm on boards are the Colon Cancer Coalition, Fight Colorectal Cancer, Colorectal Cancer Alliance, AACR, ASCO, National Coalition for Cancer Survivorship, NCCRT, and SWOG, just to name a few. I want just to show this picture real quick, and I'll show a few more pictures at the end of this to show how far I've come. The picture of me wrapped up is after my first surgery. My dad took it. I wasn't quite awake yet, but it was the lowest of the low. It was when I was at my worst. I was 80 pounds. I could barely eat or drink, and I had just started chemotherapy and radiation and just come out of my first surgery after that. It was a long journey, a very hard journey, but as I recovered, I realized that my new mission in life was to help others. So I moved from cancer research into health disparities, and now public health. I work in helping educate healthcare providers. The other picture of me is on the right, just a year ago, and you see I have a permanent ostomy as a result of my treatment. And I also try to help break the stigma that exists around ostomies. And so it says, check your colon on it. So my whole goal is to help prevent and to promote prevention and early detection of colorectal cancer, especially in the younger population, and break the stigma that exists around ostomies, because my ostomy saved my life and it gave me a much better quality of life. And that isn't talked about nearly enough. So my updates, a lot of them have to do with ASCO GI that I just attended. They're on the same trends that I would have talked about, but I wanted to wait until after I attended that. And I'm going to leave most of the scientific stuff, NEST1 and ctDNA, to the healthcare providers, but I wanted to at least put them on here. And I wanted to go more into the facts and figures that came out recently from the American Cancer Society and supportive care for people that have had colorectal cancer or have colorectal cancer. So we're going to start with the facts and figures. And as you all know, the stats was going to be by 2030, colorectal cancer was going to be the leading cause of cancer-related death in people under the age of 50. But now colorectal cancer is the leading cause of cancer-related death in men and the second leading cause of cancer-related death in women. And this is frightening. This is so, so frightening. Luckily, at GIA ASTRO, they addressed this. And one of the keynotes was Dr. Cathy Eng, who I respect greatly. And took the takeaways from that. Some of those I'm going to bring up here because I think they're really relevant and important for everyone to hear, no matter if you were at the meeting or not. So they were in 3 different categories. The first category was clinical care. And in that one, it just said, it focused on a call to action of having more specialized centers for young adults and having navigation and psychosocial support and support services for things like fertility and sexual health, which we're going to go into when we talk a little bit more about supportive care, because there was another whole section at ASCO GI about supportive care. The next call to action in clinical care was universal germline testing for all young patients, which I 100% agree. It's a lot and it's a change to what's going on now, but I very much agree that, we talk about average risk, but we need people to better understand high risk and genetics that are related to colorectal cancer, especially in younger patients. Then the next thing is genomic profiling to discover targeted therapies. I got traditional treatment, chemotherapy, radiation, surgery, all this stuff, but targeted therapies are making life so much easier. I say so much easier. Targeted therapies are just better. Looking at the tumor type, the genes that make up the tumor, and giving specific treatment related to that. It seems to be the trends are less harsh and easier on the patient. Quality of life is better. I have a lot of long-term side effects that I didn't talk about as a result of my treatment. A lot of them have to do with the radiation, long-term kidney effect, osteoporosis. I went into menopause. My sexual health was affected. So I really think that targeted therapies have the potential to increase quality of life for all people with colorectal cancer. Then the call to action for public health, the second category, was educating. And we're doing a really good job of educating the general public and the healthcare community about colorectal cancer, even medical students. The goal is to have them know if they get a patient, no matter what field they're in, if they come in with any sign or symptom for colorectal cancer, they know right away to ensure a patient gets screening. Erasing the stigma that exists associated with CRC symptoms and prevention. So different things that people do are get on social media, do talks, do as much as they can to tell their story. And advocates like me are always talking about our story to help break the stigma and get people to get screened for colorectal cancer. Most of you know, if you know me well, that I will get on social media in a poop emoji costume and talk about the importance of screening and early detection and give people colonoscopy tips and tricks, because I've had 30 plus in my lifetime. I'll do whatever, and I think there needs to be more of that. There's a lot in March, but it needs to be throughout the year so that people really understand the importance of screening and early detection, because it is one of the few cancers that is preventable through screening. Promoting a healthy lifestyle early in life. Everything's fast, processed food, red meat, all this stuff. I think talking about, what 20 minutes of exercise a day can do, and what eating and cooking vegetables and real food can do for your body to help with prevention and early detection. Then we have research. And I think this is very important. And there's so many amazing researchers out there that I work with and I volunteer with on a regular basis that are doing amazing work. I think we need to continue that. I will fight for policy so we can get more research funding. But in the meantime, some things in that general category that Dr. Eng suggested was large perspective cohort studies throughout life. Definitely, we need to figure out what's going on. Investigate environmental exposures. Like why am I at higher risk being young versus someone that is much older? Like what are the trends that are happening in the environment? And then international collaborations and pooling of cohorts and specimen. The more data we have, the better, so we can see trends and make a difference and improve care. So the next thing on here, and that's just a little bit of information about what we need to be doing and what's going on in the world with colorectal cancer and early onset. There's a lot more that I'll talk about in supportive care. And again, I know some more people will go into this in their talk, but ctDNA is here to stay. That's the next thing on here. It is not going anywhere. And that really showed at ASCO GI. It's one of the most powerful prognostic factor for recurrence in CRC, but we need larger prospective cohorts with strategies to facilitate efficiencies. So we have Bespoke, Cobra, Dynamic, Galaxy. All of them were talked about at ASCO GI. And again, I know that the other people that are presenting are going to speak. And so I'm not going to focus too much time on those because those will be gone into more detail. But essentially, it's here to stay, and we need to embrace it, or we should embrace it, is sort of the takeaway we got in 2023 and beyond. The next one on here, again, I know a lot of the buzz at ASCO GI and in the colorectal cancer field was about the NEST-1 trial. And again, I know that the healthcare providers will go into this, but the key takeaway for me and the colorectal cancer community and the people that I'm going to talk to about this are early stages MSS and MSI high. There was a substantial and brisk response to just one dose of ball immunotherapy. And immunotherapy is one of those things that also less long-term side effects, better quality of life for everyone involved. So this is a preliminary trial. I know they're now going to be recruiting even more people, but at ASCO GI, he presented, Dr. Conci presented unprecedented tumor shrinkage and robust biomarker response in prevalent colorectal cancer populations. And it didn't delay surgery at all. And that was one thing a lot of people were asking. Well, if you do this and you delay surgery, are you going to, make the patient worse? That is not the case at all. And again, I'm not going to go too much more into detail because I don't have that much time, but I know that you're going to be hearing a lot more about the NEST-1 trial. And this is a group of patients that will benefit from this based on the first pilot. The next thing I want to talk about is supportive care, and that goes along a lot with, early age onset colorectal cancer, but just in general to help prevent cancer, quality of life, to increase quality of life, to prevent a lot of things that potentially might cause harm or just decrease quality of life. And some of those things that came up are limited duration of oxyplatin. Less is more. This came up last year in my talk as well. Less is more. Less K-pops, less Fulfox, less less of these chemotherapy drugs, so that less long-term side effects for the patient. And there was no difference in X amount versus twice as much. So if you can limit the duration of some of these chemotherapy drugs and increase the quality of life, then you should do that. The next thing that they talked about in the supportive care at GI ASCO, that again has been something that we've talked about for a long time, fertility preservation. When I was getting treatment in 2012, there was not much you could do besides freeze your eggs. Now there's so many other things that you can do related to fertility preservation for male and females, and that should be offered at the very beginning, that first appointment when a patient comes in. Then we have sexual health and pelvic floor therapy, and sexual health is not talked about nearly enough. And I'm going to read you some stats that have come out or that have been around for a while, but might surprise you. 75% of patients with CRC experience sexual concerns. 1/3 cease sexual activity due to dysfunction. Only 11% of women recall discussing sexual health with their medical team, and 20% of men. Now, this is not okay. That 11% should be 100%. That 20% should also be 100%. Sexual health and talking about that and dealing with it head on during treatment can increase quality of life. And I know I've said quality of life a zillion times, but it's a shared decision-making thing. Shared decision-making needs to be talked about with the patient regarding fertility, sexual health, duration of chemotherapy, And then pelvic floor therapy is something that I did 8 years after my treatment, but it made a huge difference. And it would have made an even bigger difference if I had done it during my treatment. Last on supportive care is LARS. And LARS is something I hear about often from patients when they reach out and ask me about, what can they do about this? And I had LARS before I had my ostomy, and it was not great. And there was a session at GI ASTRO that talked about pelvic floor therapy, what I mentioned earlier, helping with LARS, medication, sacral nerve stimulation for men, and a lot of different things that can be done to help increase or to help prevent the effects of LARS on the patient. And so it's something we need to address. It's something we need to have more talks about. And it's something you need to bring up with your patient when we're talking about surgical options. Because the stigma of an ostomy is one that is huge for a patient. And I think that there's a disconnect. And there was also another talk at ASCO GI that talked about the disconnect between patients and their clinicians and what was important to them. And it's interesting because the patient values were totally different and essentially reversed. So cancer recurrence and colostomy were pretty much flipped between patients and clinicians, with the patients highly valuing quality of life and avoiding having a stoma, and their doctors thought opposite. And I think that goes back to what was talked about with early onset. We need more education. We need more awareness. We need to break more this negative stigma that exists, because again, my ostomy saved my life. I talk to patients often when they're about to have one or they have a stoma, even if it's temporary, to talk about what I did to increase my quality of life. I still can exercise. I can still travel. I can do everything. I can do it actually easier with my stoma. So knowing that patients want to avoid a colostomy at all costs, understandable. But if it's a better surgical option for them and it will increase their quality of life, they need to know about that. And I urge you, if you're a healthcare provider listening, to have them talk to someone who has an ostomy already, just so they better understand that their life is not over once they have an ostomy. It's in my case, it finally began. And so these are a view of the colorectal cancer trends I noticed in 2023, and especially ones that came up a lot at GI ASCO. I want to end my talk with, I talked about quality of life. I talked about advocacy. I talked about the patient voice. If you don't have a patient helping guide you in clinical trials or your research or anything that you're doing in your clinic that involves, patients, I urge you to find an advocate. I'm happy to help you find an advocate that can show you, teach you, and help you better understand what the community wants. We're in the online groups on Facebook and Instagram, and we know what's going on in the community, and we have people reach out to us to help navigate all the time. And they do this because I post myself living life to the fullest. You see all these pictures. I have my healthcare providers in the bottom. I'm involved in a race called Get Your Rear and Gear Houston that I'm the event director for. I climb mountains. I show my ostomy. I go to scientific conferences. Again, it's a blend of traveling the world and seeing things and living life to the fullest, and then educating, advocating, and collaborating to help work with people like you listening, healthcare providers, other patients, and advocacy organizations to help end this disease in our lifetime. I really want my purpose in life to be your purpose. I went through everything I went through to help prevent other people from having to go through what I went through. And I know that's what we all want. We want to better understand this disease and help we can treat, beat, and prevent. And so with that, I want to thank you for including the patient voice in this colloquium. And I look forward to the other presentations. And you can find me on X, Twitter here. I'm happy to collaborate and help you with anything you're doing related to colorectal cancer or AYA cancer or other cancers. Because I just want my story to have a purpose. My life purpose is to educate and help as many people as I possibly can. So thank you.
Hi, my name is Ben Westphallen. I'm a medical oncologist and molecular biologist by training. And today I would like to talk to you about GI controversies of 2023. I'm deeply grateful to Gill Morgan and OncoAlert for allowing me to speak at this year's OncoAlert Colloquium. These are my conflicts of interest, none of which have influenced today's talk. It took me quite some time to choose topics for this controversy talk, and I had help and advice by some great colleagues from the GI oncology field, and I will show them to you later when I thank them for their support. So in the end, I decided to talk to you about neoadjuvant treatment of resectable pancreatic cancer and liquid biopsies in the management of resectable colorectal cancer. Let's dive right into neoadjuvant therapy in pancreatic cancer. What are the considerations here on neoadjuvant treatment in pancreatic ductal adenocarcinoma? Some may argue that pancreatic cancer is a systemic disease from the get-go. After resection, not all patients receive adjuvant treatment. With neoadjuvant treatment, on the other hand, all patients receive at least some systemic therapy. Then we have to consider whether our current treatment regimens, Gem/nab-paclitaxel and FOLFIRINOX, are indeed effective enough to serve in the neoadjuvant or perioperative setting, or maybe they're just not effective enough. Then some metastatic patients that are occult may be spared surgery because their metastatic disease becomes visible during the time of neoadjuvant treatment. There's a question of better surgical outcome after neoadjuvant and conversion from borderline resectable or locally advanced to resectable pancreatic cancer. Another question is whether we are hitting a wall. This is data from the seminal PRODIGE trial of FOLFIRINOX against gemcitabine in the adjuvant setting. With maximal intensification of adjuvant treatment in this highly selected population, an improvement from 19 to 26.1% in the 5-year disease-free survival is observed, and there's really nothing we could do to further intensify this treatment regimen, and there's nothing on the horizon that would warrant large hope that improving outcome in the adjuvant setting is feasible in the short term. Is there evidence for neoadjuvant treatment? Here you see a SEER data analysis published in the JCO in 2016 that suggests that patients receiving neoadjuvant treatment with resectable pancreatic cancer have a survival benefit over upfront resection and adjuvant treatment, but these retrospective analyses are prone to bias, so randomized evidence is needed to answer the question if perioperative or neoadjuvant treatment is effective and feasible in pancreatic cancer. I had the great pleasure and honor to co-write an editorial accompanying NORPAC-1 in Lancet Gastroenterology and Hepatology with Grania O'Kane, and we tried to digest the data from the clinical trials reported of neoadjuvant or perioperative treatment in resectable and borderline resectable pancreatic cancer. It will go too far to dive deep into the data presented here, but let me tell you, there is no clear evidence up to now, and the data is very heterogeneous, so further evidence from randomized clinical trials is needed. In 2023, we saw PREOPANC2 and NORPAC-1 being presented, and this is the first controversy that I would like to discuss with you today. PREOPANC2 was a randomized phase 3 clinical trial of total neoadjuvant treatment with 8 cycles of FOLFIRINOX followed by surgery and surveillance versus the winner arm of PRIOPANC-1, gemcitabine followed by gemcitabine-based radiochemotherapy, gemcitabine surgery, and adjuvant gemcitabine. A total of 368 patients were randomly assigned to this trial. The primary endpoint of this trial was overall survival. 95 and 96% respectively of patients started neoadjuvant treatment. 88% of patients in the gemcitabine chemoradiation arm completed neoadjuvant treatment versus 62 patients that received all 8 doses of FOLFIRINOX. Surgical exploration happened in 84 and 90% respectively, and 77% in the FOLFIRINOX arm and 75% in the gem chemoradiation arm were resected. To cut a long story short, there was absolutely no difference in overall survival in between the two arms, which is surprising, but in the end, this is what the data shows. And I believe this well-designed and randomized clinical trial should be the benchmark for further trials investigating neoadjuvant or perioperative concepts in pancreatic cancer. Coming to NORPAC-1, presented at last year's ASTRO, NORPAC-1 tested neoadjuvant full-dose FOLFIRINOX versus upfront surgery for resectable pancreatic cancer in a phase 2 trial setting. 140 patients were randomly assigned to receive either neoadjuvant FOLFIRINOX or upfront surgery. I'm going to walk you through the consort diagram, but bearing the shortness of this talk, I advise you to look at the full manuscript out in Lancet Gastroenterology Hepatology, because the devil is in the detail here. So in the end, 61 patients in the neoadjuvant FOLFIRINOX arm received FOLFIRINOX, but out of the 77 assigned to the arm, 71 patients went into surgery. From the 63 patients in the upfront surgery, 62 received surgery in the end. 63 patients in the neoadjuvant arm underwent resection. Bear in mind that only 61 patients received FOLFIRINOX and 56 patients in the upfront surgery arm in the end were resected. 51 patients in the neoadjuvant arm also received adjuvant chemotherapy and 47 in the standard of care arm. 60 patients in the FOLFIRINOX arm were included in the per protocol analysis. And this is important because these were the patients that had the histopathological diagnosis of pancreatic ductal adenocarcinoma and received at least one cycle of FOLFIRINOX. And in the upfront surgery arm, those were the patients that had histopathological diagnosis of pancreatic ductal adenocarcinoma and received surgery. So bear in mind that a significant fraction of patients in this clinical trial did not have pancreatic cancer. The primary endpoint was overall survival at 18 months after the date of randomization. This is data from the intention to treat analysis, so all patients being randomized, including those not having pancreatic cancer. And you see that there was a significant benefit of receiving upfront surgery when compared to neoadjuvant FOLFIRINOX. In patients with pancreatic cancer that received at least one dose of FOLFIRINOX according to protocol, you see that the difference in progression-free survival was not significant in between the arms, and there was still a significant benefit of upfront surgery over neoadjuvant FOLFIRINOX in the intention to treat population. The median overall survival in the intention to treat was significantly longer in the upfront surgery group, while median progression-free survival and the proportion of patients alive and disease-free at 18 months was not significantly different in between the two groups. Importantly, and as I said, the devil is in the detail, treatment density in this trial was different in between groups, and in the neoadjuvant group, 30% of patients received just 1 or 2 cycles of FOLFIRINOX, and only 60% of the patients here received all 4 cycles of FOLFIRINOX. So as I said, treatment intensity might be a problem here. To discuss this first set, conducting clinical trials in resectable pancreatic cancer remains challenging. Survival outcomes in adjuvant trials cannot be used as benchmark as of the selection bias. PREOPANC2 did not find a difference between total neoadjuvant and perioperative treatment, but could be used as a benchmark for further trials in this setting, and NORPAC1 did not show a benefit of neoadjuvant full dose FOLFIRINOX over upfront resection. So now jumping to liquid biopsies in the management of resectable colorectal cancer. In this beautiful NCI colon and rectal anal task force white paper, the multiple applications of ctDNA in the management of colorectal cancer are outlined, and today we would like to look at minimal residual disease after resection. Gionanni and colleagues presented data of the dynamic trial published in the New England Journal in 2022, showing that ctDNA analysis can guide adjuvant therapy in stage 2 colon cancer, showing that there was absolutely no difference in recurrence-free survival when patients received standard management compared to ctDNA guided management. At ESMO 2023, my dear colleague Sara Lonardi presented data of the Pegasus trial of post-surgical liquid biopsy-guided treatment in patients with stage 3 and high-risk stage 2 colon cancer. This was the trial design. I won't go into too much detail today to have time on discussing the data, and I find this endpoint, false negative cases, extremely interesting, because what you want to know when you run a trial using treatment intensification or de-intensification is which patients do not benefit from your novel intervention. 135 patients were analyzed as per protocol, and overall 26% were ctDNA positive, 21% in a low-risk group, and 32% in the high-risk group. As in previous clinical trials, ctDNA positivity was a strong predictor of inferior outcome and was actually stronger in predicting outcome than the clinical stage. With a focus on ctDNA negative patients experiencing relapse, so the false negatives, an interesting finding occurred. While patients that had local recurrence or recurrence in the liver became liquid biopsy positive, that was not necessarily the case in patients relapsing with lung or peritoneal mets. And this was shown in both the initially ctDNA negative and ctDNA positive patients. So the conclusions from Pegasus here. The MRD rate was similar to retrospective and prospective studies. The strong prognostic effect of ctDNA was confirmed in this population. At a median follow-up of 21 months, 10 false negatives have been observed, and there's still a little bit of time of follow-up needed. Seroconversion of MRD positive patients at the end of any treatment is 40%, which is important, and site-specific ctDNA detection and clinical relapses suggest lower accuracy of the test in local lung and peritoneal minimal residual disease. So why is this a controversy? Now diving deep into the data discussed by Chiara Cremolini, the whole world is waiting for the liquid biopsy revolution, and you have a lot of ongoing and upcoming ctDNA guided clinical trials. You see that the rate of false negatives is different in between trials, ranging from 6% to 24%, so it really depends on the assay that you are using. So the conclusions from the discussions by Chiara Cremolini are: we know that ctDNA has a strong prognostic impact post-surgery, and it is stronger than stage. False negatives are more frequent in the case of local regional, lung, and peritoneal relapse. And what we really need to know is the reliability of blood-based only tests and the role of ctDNA clearance as a surrogate of cure and the impact of post-adjuvant treatments. So you really have a lot of open questions, but me as a precision oncologist, I'm really glad that these technologies come into maturity. With this, I would like to thank my dear colleagues from the GI oncology field in this picture, and Julian, Benedikt, and Andrea for providing also their insight on what would be useful to discuss here. And with this, I thank you very much for your attendance, and I'm happy to take questions. Thank you very much.
Hello, my name is Eric Miller. I'm the lead GI radiation oncologist and associate clinical director for the Department of Radiation Oncology at Ohio State University. Very excited to participate in the OncoAlert Colloquium, so thank you for taking the time to listen to my updates in GI radiation oncology in 2023. Here's my agenda. As you can see, we'll work our way around the different GI disease sites, starting with gastroesophageal cancer. So NeoAegis was reported at ASCO GI in 2023 and also published this year. This is a randomized phase 3 trial which included 377 patients with stage 2 or 3 esophageal or gastroesophageal junction cancer, and randomized patients to either perioperative chemotherapy or cross neoadjuvant chemoradiation. For the perioperative chemotherapy, the modified MAGIC regimen was used from 2013 to 2018. This was later changed to FLOT from 2019 to 2020. Chemoradiation consisted of the cross regimen of 41.4 gray and 23 fractions and weekly carbotaxol. Primary endpoint of the study was overall survival. Most patients had T3 and node-positive disease. Approximately 15% of patients in the perioperative chemotherapy group received FLOT. After a median follow-up of 38.8 months, 3-year overall survival was similar between the two groups, 55% in the perioperative chemotherapy group and 57% in the trimodality therapy group. Of note, the trial was originally powered to detect an increase in overall survival with trimodality therapy over perioperative chemotherapy, but was later changed to a non-inferiority design when FLOT was permitted. The study was subsequently closed early following a second futility analysis prior to meeting its planned enrollment target, so non-inferiority could not be established. However, equipoise is suggested by these results. When assessing markers of local treatment response, however, they favored trimodality therapy, including tumor regression grade, pathological complete response, R0 resection status, and endoscopic response. Similarly, when evaluating toxicity, more diarrhea, vomiting, hematologic toxicity, peripheral neuropathy, and alopecia was observed in the perioperative chemotherapy group and the cross-regimen group. We still await the quality of life results for this study, as well as the results of the ESOPhic trial to help bring some clarity to this clinical question. I do want to quickly highlight two trials in esophageal and gastroesophageal junction cancer in NRG oncology that are accruing. The first is NRG-GI006, which is a phase 3 randomized trial of patients with thoracic esophagus or gastroesophageal junction cancer, investigating proton versus photon-based chemoradiation. The study is a co-primary endpoint of overall survival and development of grade 3 or higher cardiopulmonary adverse events. So please keep this study in mind as you're seeing patients as accrual is about halfway complete. The second study is NRG-GI007. It's a phase 1 trial with expansion cohort in patients with esophageal cancer eligible for a non-operative approach, investigating intratumoral injection of an oncolytic virus, OBP301. The study is now accruing to the expansion cohort. Moving on to pancreas cancer. The SMART trial was presented at ASTRO this past year and then published in the Red Journal. This is a multi-institutional single-arm phase 2 study which evaluated the safety of 5-fraction MR-guided adaptive radiation therapy in patients with locally advanced and borderline resectable pancreas cancer. Patients received a minimum of 3 months of systemic therapy without evidence of distant progression. 50 gray and 5 fractions was prescribed on a 0.35 Tesla MR-guided radiation delivery system. Primary endpoint was acute grade 3 or higher GI toxicity that was definitely attributed to SMART, which was robustly evaluated in this study. For patients included on the trial, pancreas head lesions were the most common site. Induction chemotherapy mostly consisted of modified FOLFIRINOX in 65% of patients, and most patients had locally advanced disease. On-table adaptive replanning was performed for over 90% of all delivered fractions. At a median follow-up from SMART of 8.8 months, the incidence of acute grade 3 or higher GI toxicity, possibly or probably attributed to SMART, was 8.8%, including two postoperative deaths that were possibly related to SMART in patients who had surgery. The 1-year overall survival from SMART was 65%, while local control was 82.9%. The authors conclude that the primary endpoint of the study was met with no acute grade 3 or higher GI toxicity that was definitely attributed to SMART. However, the authors also mentioned that due to 2 deaths possibly related to treatment, caution should be exercised when pursuing surgery, especially with vascular resection after SMART. So a very promising outcome for patients with pancreas cancer and one that warrants additional investigation. Let's move on to hepatobiliary cancer. So the TRENDI trial is a multi-center randomized phase 2 trial which compared DEB-TACE with SBRT in patients with hepatocellular carcinoma. Patients were ineligible for surgery or ablation, but those requiring treatment for liver transplantation were included. Patients needed to be Child-Pugh A and had 1 to 3 tumors with a cumulative diameter of 6 centimeters or less. For the TACE arm, up to 4 procedures were allowed, and additional ablation was permitted at the center's discretion. SBRT was delivered in 6 fractions of either 8 or 9 gray per fraction. The trial was originally designed to randomize 100 patients. Due to slow accrual, was stopped after 30 patients, 16 in the TACE arm and 14 in the SBRT arm. However, 2 patients in the SBRT arm were ultimately ineligible, and an additional patient was treated with TACE due to fiducial marker issues. The primary endpoint of the study was time to progression. Here's a summary of patients included on the trial. Few patients had previous treatments, about half were planned for liver transplantation. All patients had 1 tumor treated with a median size of about 3 centimeters. For the primary endpoint of time to progression, the median was 12 months in the TACE arm and 18.8 months in the SBRT arm. For local recurrence, the median time to local recurrence was 12 months in the TACE arm and more than 40 months in the SBRT arm in the intention to treat population. However, looking at the per protocol population and taking into account compliance with SBRT quality assurance with the post hoc analysis, this analysis revealed a difference in local control between the 2 arms. There was no difference in overall survival between the 2 arms. For toxicity, there were 3 episodes of grade 3 or higher toxicity related to treatment in the TACE arm and none in the SBRT arm. Quality of life measures were similar after treatment in both arms as well. So while underpowered with small patient numbers, this prospective study does provide some interesting insight into the role of SBRT versus TACE in the management of HCC, but needs to be validated with larger studies. HE1 trial is a study presented at ASCO GI in 2023 from the Canadian Cancer Trials Group that was led by Dr. Laura Dawson, evaluating the role of palliative radiation therapy in patients with symptomatic hepatocellular carcinoma and liver metastases. So this is the trial schema. The trial included patients with advanced liver cancer with stable pain that was more than 4 out of 10 at baseline. Patients were then randomized to best supportive care with or without the addition of a single fraction of radiation, A-gray, with pretreatment antiemetics. Pain was reassessed on day 30 and day 90 with the option of crossover after the 1-month assessment time point for the best supportive care arm. These are simple radiation plans with A-grade delivered to the whole liver with an example plan shown here. The primary endpoint of this study was the proportion of patients with improved pain on brief pain inventory by 2 or more points from baseline to 1 month. 66 patients were randomized with 42 patients completing the baseline and 1-month assessment. A third of patients on the best supportive care arm crossed over to receive radiation at 1 month. For the primary endpoint of the study, patient-reported pain at its worst improved by 2 points or more was observed in 67% of patients who received radiation therapy versus 22% who received best supportive care. This was statistically significant. In addition, there was a trend for improved 3-month overall survival for those patients who received radiation therapy, again, showing the value of this potential palliative radiation treatment for those patients with advanced HCC or liver metastases. I did want to quickly mention an ongoing study in HCC being conducted through NRG Oncology, NRG GI003. So this is a phase 3 randomized study led by Dr. Ted Hong comparing proton and photon therapy. A little over halfway accrued, so this is an important question, so please keep this study in mind. Moving on to rectal cancer, which will take the majority of our time because of all the updates at this disease site. So one of the big studies that we've been waiting for was presented at the ASCO plenary session and published in the New England Journal of Medicine, the PROSPECT trial. So the schema is shown here. So this study included patients with clinical T2N1 or T3N0 or N1 rectal cancer. No positivity was defined as at least one perirectal lymph node that was 5 millimeters in size or larger, and no more than 4 perirectal lymph nodes larger than 1 centimeter in size. So essentially N1 disease without bulky lymph nodes. Patients also could not have tumor visible within 3 millimeters at the radial margin at baseline and needed to be eligible for a sphincter-sparing surgical resection prior to starting any neoadjuvant treatment. Patients were randomized to receive either standard chemoradiation with a dose of 50.4 gray and 28 fractions with fluoropyrimidine chemotherapy, followed by 2 mesorectal excision, and then adjuvant chemotherapy with 8 cycles of FOLFOX ingested, left to the discretion of the treatment team, versus 6 cycles of FOLFOX followed by restaging with imaging and endoscopy. Patients who were unable to finish at least 5 cycles of FOLFOX or patients who did not have a 20% response went on to receive chemoradiation. Those with more than a 20% response went on to surgical resection. An additional 6 cycles of adjuvant chemotherapy was suggested. The primary objective of this study was to determine if neoadjuvant FOLFOX with selective use of chemoradiation would be non-inferior to standard treatment with disease-free survival as the endpoint. The study randomized 1,194 patients with 1,128 patients starting treatment and included in the per-protocol analysis. As you can see from a summary of Table 1 from the manuscript, these were mostly mid-rectal cancers with about half being T3 and node positive. MRI staging was used in 84% of patients. At a median follow-up of 58 months, the results showed that in select patients with rectal cancer, preoperative chemoradiation could be selectively replaced with FOLFOX and omission of radiation therapy in those with a good initial response to chemo without a detriment to disease-free survival. 5-year disease-free survival was about 80% in both groups. 5-year overall survival was about 90% in both groups, and the 5-year local recurrence rate was about 2% in each of the arms. Some of the key secondary and pathological endpoints from the study are shown in this table. As you can see, rates of R0 resection, pathologic complete response, type of surgery performed, and radial margin status were similar between the two groups. Overall, about 10% of patients in the neoadjuvant FOLFOX group received chemoradiation at some point, about 9% before surgery, and about 1% after surgery. In the FOLFOX group, about 80% received adjuvant chemo, with most completing 6 cycles. Also, about 80% of patients in the chemoradiation group also completed adjuvant chemotherapy. Regarding clinician-reported toxicity during preoperative treatment, while the observation period was at least twice as long for those in the neoadjuvant FOLFOX group compared to the chemoradiation group, a higher number of grade 3 and grade 4 or higher adverse events were observed in the FOLFOX group compared to the chemoradiation group. A summary of some of the toxicities reported are shown here, with the blue highlights indicating those that were higher in the neoadjuvant FOLFOX group, and the red highlighting those that were higher in the neoadjuvant chemoradiation group. As you can see, chemoradiation group diarrhea and pain were higher, while most of the other toxicities were higher in the FOLFOX group. This is a summary of clinician-reported toxicity during postoperative treatment, again with those on the FOLFOX arm receiving 6 cycles of adjuvant FOLFOX versus 8 cycles for those on the chemoradiation arm. While the rate of grade 4 or higher rate of grade 4 or higher toxicities were similar between the groups, most of the other reported toxicities were higher in the chemoradiation group than the FOLFOX group, with the exception of peripheral neuropathy. When assessing patient-reported quality of life with the pro-CTCAE measures, most of the toxicity measures were reported as significantly higher in the FOLFOX group during neoadjuvant treatment, as shown in this summary slide, with the exception of diarrhea that was higher in the chemoradiation group. At 12 months after surgery, rates of fatigue and neuropathy were significantly higher for the chemoradiation group. Bowel function was better during neoadjuvant treatment with FOLFOX, but was similar at 12 and 24 months after surgery. Sexual function was better in the FOLFOX group at 12 and 24 months after surgery. However, overall health-related quality of life did not differ between the groups at any time point. So overall, PROSPECT confirms that in a subset of patients with rectal cancer, there is another treatment option to consider, depending on which toxicities patients find most acceptable and in conjunction with their decision for surgical resection versus organ preservation. This year, there are also a couple of updates on studies that were previously published, including the Rapido trial. So as a quick refresher, this study included 920 patients with high-risk rectal cancer and randomized patients to either standard treatment with neoadjuvant chemoradiation, followed by total mesorectal excision, with adjuvant systemic therapy per investigator discretion versus short-course radiation therapy, 25 gray and 5 fractions, followed by consolidation chemotherapy, and then total mesorectal excision. Here are the high-risk criteria and the percentage of patients who had each. 65% of patients had N2 disease and 60% had mesorectal fascia involvement. Over 60% of patients had 1 to 2 high-risk factors. So the primary endpoint of the study was reported in 2021, and just as a reminder, it was disease-related treatment failure, which was this composite endpoint, which including several measures, including distant Mets, local regional failure, a new primary colorectal cancer, or treatment-related death. And this was changed from the initial primary endpoint of disease-free survival when the study was originally designed. There was a statistically significant improvement in DRTF in the TNT group compared to the standard treatment group. This was driven by a reduction in risk of distant metastases. There was no difference in overall survival or local regional failure observed at the initial reporting of this study. So a 5-year update of the study that was published this past year and reported on one of the secondary endpoints of the study, which is local regional failure. So local regional failure included both early local regional failure, which was defined as patients who did not undergo surgery or underwent non-resectional surgery unless for non-operative management or underwent an R2 resection. Local regional recurrence was defined as recurrence after a prior R0 or R1 resection. So of note, the location of recurrence was centrally reviewed. So at a median follow-up of 5.6 years, the rate of local regional failure was 11.7% in the TNT arm versus 8.1% in the standard group, which was not statistically significant. There were 10 patients in each group who had an early local regional failure. However, the TNT group, which included short-course radiation therapy, was associated with a higher rate of local regional recurrence compared to the standard group, 10.2% versus 6.1%. This is summarized by the figure on the left. So this difference could be for several reasons, and these reasons were really highlighted and summarized really nicely in an editorial in the Red Journal by Dr. Chris Jethwa and others, which I would really encourage everyone to read. Just to kind of quickly summarize that article. So short-course radiation was associated with a higher risk of mesorectum breach than long-course chemoradiation. So could the increased local regional occurrence be due to increased surgical complexity due to the length of time between completing radiation and surgical resection? It's possible. Could it be due to radiation technique, or could it be due to the lower biologically effective dose that is delivered with short-course radiation compared to long-course chemoradiation? Also potentially true. So it remains a question still open for discussion, one that we don't have an answer for quite yet. There was also an update on the OPRA trial. As a quick reminder, this is a randomized phase 2 study, which included patients with stage 2 or 3 rectal cancer randomized to either induction chemotherapy followed by chemoradiation or chemoradiation followed by consolidation chemotherapy. Patients would then be reevaluated and would undergo non-operative management, with close surveillance if they had a complete clinical response, or total mesorectal excision if they had residual disease. The trial was designed as 2 standalone studies with disease-free survival as the primary endpoint for both groups. It was not powered for a formal comparison between the groups. The 5-year update was in line with what was observed at 3 years, with disease-free survival rates of 70%, which were favorable. TME-free survival was 39% in the induction chemo first group and 54% in the chemoradiation first groups, again highlighting that chemoradiation first may increase your chances of potentially avoiding a TME. Of those patients who had regrowth, 94% occurred within 2 years and 99% occurred within 3 years, providing further insight into surveillance of patients who pursue non-operative management and looking at the timing of regrowths. Long-term results of PRODIGE 23 were also presented at ASCO this past year. It's a quick refresher. This is a French trial of 461 patients with locally advanced rectal cancer who randomized 1-to-1 to either standard of care treatment consisting of neoadjuvant chemoradiation followed by total mesorectal excision and then adjuvant chemotherapy versus 3 months of modified FOLFIRINOX followed by chemoradiation, TME, and then 3 more months of adjuvant chemotherapy. It's a quick summary of the patients who were included in this trial. Most patients had mid or low rectal tumors. Approximately 80% were T3, nearly 90% had involved lymph nodes, and about a quarter of patients had a concerning mesorectal radial margin at presentation. The primary endpoint of the study was disease-free survival. For the 7-year analysis, the proportional hazard assumption was invalid, so restricted median survival time was used with the 7-year endpoint. The DFS rate after 7 years was 67.6% in the FOLFIRINOX arm versus 62.5% for the standard of care arm, the restricted median survival time benefit of 5.7 months, which was statistically significant. A significant improvement in overall survival was also observed, largely driven by an improvement in distant control. Some questions do remain about this study, including how does triplet therapy with FOLFIRINOX compare to FOLFOX? And this is the subject of an ongoing study in rectal cancer, the JANICE trial, which is led by Dr. Smith. Just to highlight this ongoing trial, so this is a randomized phase 2 trial of patients with locally advanced rectal cancer being conducted through the NCTN, investigating if escalation of consolidation systemic therapy can increase the clinical complete response rate to allow more patients to pursue non-operative management. So following long course chemoradiation, patients are randomized to either consolidation FOLFOX or CAPOX or modified FOLFIRINOX, followed by a response assessment. The primary endpoint of the study is clinical complete response rate. The study is accruing very well now at nearly 2/3 accrual, being open a little over a year. The second ongoing study that I wanted to mention is the ERASER trial, and this is a joint trial between Alliance and NRG Oncology, led by myself, Dr. Kate Hitchcock, and Dr. Paul Romisser. It's investigating the role of total ablative therapy in patients with limited metastatic colorectal cancer. So it includes patients who have up to 4 sites of disease on baseline imaging. They receive induction systemic therapy for 16 to 26 weeks. Those patients who don't progress on systemic therapy are then randomized to continue standard of care systemic therapy with or without the addition of total ablative therapy to all metastatic sites. And total ablative therapy, or TAT, includes SABR, SBRT, with or without surgery, or with or without microwave ablation. And the primary endpoint of the study is overall survival. Here's how we're defining a metastatic site. So it's 4 or fewer apparent sites of metastatic disease at baseline imaging. Pathologic confirmation of at least 1 site is required. Single sites include each hemiliver, each lobe of the lungs, each adrenal gland, lymph nodes amenable to a single resection or single SABR field, and bone mets that are amenable to a single SABR field. There's no restriction on the number of lesions per site. Just to give an example patient, so this patient that has 3 lesions in the right upper lobe, 3 lesions in the right liver, and 1 lesion in the left lower lobe, each of those would be considered 1 site. That's within the 4-site criteria. So this patient would be considered eligible for this study. So there's no restriction on the number of lesions per site. This study is open and enrolling, so I would encourage you to consider opening this study at your site. If you do have it open, please remember this study as you're talking to patients with newly diagnosed metastatic colorectal cancer. Last but not least is anal cancer. So we did have early results from the Plato-4 trial this year, which is investigating reduced dose radiation therapy for patients with early stage anal cancer, demonstrating favorable results with such an approach. So I want to highlight a similar ongoing trial in the cooperative groups. Decrease is a randomized phase 2 trial investigating efficacy and toxicity of de-intensified chemoradiation for patients with early stage anal cancer. So patients are randomized in a 1-to-2 fashion to standard dose chemoradiation or de-intensified treatment with lower doses of both radiation therapy and chemotherapy. So accrual of this study is nearly complete, and so we anxiously await the results of this study. So thank you so much for listening to my highlights in GI radiation oncology, this whirlwind tour over the past of the studies that have been done in the past year. I want to congratulate all the study teams whose work I highlighted for performing such impactful studies. And I want to thank OncoAlert for this great opportunity. Thank you.
Good morning to everybody. My name is Giovanni De Manzoni. I'm director of the Department of Surgery of the University of Verona. And moreover, I am in the Council Board of the European Society of Surgical Oncology. My topic is today to talk about the new findings in gastric cancer surgical oncology in 2023. I would like to concentrate on 2 topics, the treatment of locally advanced gastric cancer, and another topic for me very important and will be more important in the future, treatment of stage 4 gastric cancer. Important for oncologists, but also for surgery. What about locally advanced gastric cancer? The most important achievement, in my opinion, in 2022-2023 is that we have in the literature 3 very important trials on laparoscopic minimally invasive approach to gastric cancer about distal gastrectomy, subtotal gastrectomy in locally advanced gastric cancer. The trial from China, Korea, and Japan, all these trials showed us that there is no difference in the radicality of the surgery and no difference in 5-year overall survival. So I can say that for subtotal gastrectomy for locally advanced gastric cancer, minimally invasive approach is approved. and will be put in the guidelines in the near future, not only in Eastern countries, but also in the European and Western countries. What about total gastrectomy? About total gastrectomy, there is at present still some discussion. Is weekly recommended in the guidelines in Japan and Korea because probably we have still a higher morbidity in the anastomosis, a higher percentage of leakage in the anastomosis. Anyway, there is a very important trial, stomach trial, that is a Western trial done by the European group with the Dutch colleagues coordinating this trial. And it's a trial with very few number, 47 against 49, minimally invasive versus open. Anyway, they showed us that the radicality, the number of lymph nodes excised is the same. So, and also 3-year survival, we have not still the 5-year actuarial survival. The 3-year survival seems not to be different, even if the curves are pro-open surgery compared with minimally invasive. Any case, a few cases, so we have to wait for a higher number of cases trial from the East, but also from the West. Anyway, the most important thing is the impact of the molecular evolution of the treatment of locally advanced gastric cancer. What does it mean? For example, in locally advanced gastric cancer, for HER2 patients, we have an important trial from Germany. Is a Petrarca trial that showed us that adding trastuzumab to the FLOT in neoadjuvant setting, we can have a higher complete response rate and higher number of N0 cases. So it seemed to work. Anyway, this trial was stopped. Why was stopped? Because in parallel were published another trial in a metastatic setting showing the Jacob trial that showed that even if we have more complete response, we have to pay attention because adding pertuzumab to trastuzumab and chemotherapy did not significantly improve overall survival. For this reason, the use of the HER2 target therapy is still debate in the literature, is not still in the guidelines. Anyway, there are other studies going on, and we will see in the future. What is very important for the future is the treatment in MSI cases. In MSI cases, we have realized in the past that the surgery is probably better than chemo, that chemo could be detrimental for the patient with MSI, with instability. And so at present, outside of clinical trial, the suggestion for MSI patient is upfront surgery and adjuvant chemo is not recommended. So just upfront surgery. Anyway, there are two very important papers. One is from Italy, is from the National Cancer Institute in Milan, and they use in neoadjuvant setting in MSI patient EBV negative, locally advanced, the use of tremelimumab and durvalumab together with in combination to understand if it's possible to reach a non-operative treatment. This study was divided in two cohort. In cohort 1, we participated in this study. We have seen that in patient with less than T4A, with no invasion of the serosa, we could reach 89% of complete response, T2 and T3 tumors. For this reason, in the second cohort 2, we excluded the CT4A tumors. Laparoscopic staging for this reason was mandatory to select for the second cohort. But in the second cohort, this is a single arm cohort, if we reach a complete response, with this criteria, absence of disease with the biopsy, with the bite on bite, PET CT scan negative, and also negativity for tumor at a liquid biopsy, we can suggest to the patient non-operative management. So we will see what is going to happen. Anyway, also we can suggest probably a organ sparing surgery for that patient, MSI, that had a good response to immunotherapy, but not complete response. What does it mean? That the Japanese and our Eastern colleague think about limited surgery for early gastric cancer, not suitable for endoscopic treatment. We see about organ sparing and atypical gastric resection for patients that has a very good response to immunotherapy, MSI patient, in which we can perform a basin lymphadenectomy just of the drainage basin and atypical gastric resection. This is clearly the future. What about immunotherapy in locally advanced, not only in MSI? We have a very new trial, very important, presented to the ASCO GI this year in 2024. One of this trial is a Matterhorn that showed that adding immunotherapy to FLOT, we can reach in non-MSI patient around 20% of complete response versus 7% with FLOT. These are preliminary data. Anyway, we had a higher number of T0 and also a higher number of M0 in the staging. Why is preliminary? Because in parallel, there is another important study, Keynote 585, that was also presented in ASCO GI 2024, and the addition of pembrolizumab to perioperative chemo significantly improved the pathological complete response as the Matterhorn. But we did not translate this result to a significant improvement in event-free survival. So we will see in not MSI patient what is going on about immunotherapy. But what is the problem of Matterhorn? All the trial that in which we use chemo plus immunotherapy, that there is a histotype, the diffuse histotype, that seems not to respond to this type of treatment. And this diffuse type usually are the genomically stable cancer according to the BAS classification. The diffuse type is a big problem, is increasing in a young age, especially in patients under 50 years old of age. And our problem is also the peritoneal carcinomatosis in these cases. High rate of peritoneal carcinomatosis and no response to chemo. So what we can do? From one side, there is a trial proposed by the German Society of Oncology in which the FLOT9, and in which they add IPEC, chemohyperthermia, as preventive treatment in this locally advanced cancer with diffuse signet ring cell type after FLOT to perform in the arm B always the IPEC and not only surgery. But in my group, we went deeply to study this type of tumor. We studied 64 cases with the transcriptome analysis, and we have found that there are some cluster, the cluster with epithelial to mesenchymal transition that clearly get worse. You can see the blue line, and this case is showing EMT profile as a very worse prognosis. And also we have found that this type is connected con cancer-associated fibroblasts they are present only in the metastasis from the gastric cancer in the ovary or in the peritoneum. So there is a clear connection, and CAF could be a target for our future therapies. What about stage 4? And I'm going to close my short talk. Stage 4 we have reached a very, very important result in HER2 patient with trastuzumab in the TOGA trial, but nowadays, adding immunotherapy, especially pembrolizumab, in this paper in the Lancet 2023, we have Giionanni shown that there is an improved progression-free survival with the combination immunotherapy and target therapy as first line for metastatic patient. For MSI and PD-L1, moreover, this is a very important checkmate 649 that show that nivolumab, adding nivolumab to chemo, clearly you can improve the progression-free survival in metastatic patients. So what does it mean this? And also we have a new still in the 2023, a new target, Claudin. There is this paper in which with zolbetuximab, that is a target for Claudin, you can improve the survival also in the metastatic setting in these gastric cancer patients. So we have some new weapon for this metastatic patient. And this new weapon, what does it mean? That probably we can select a class of patients that is not heavy metastatic with very poor median survival, 10.7, is not locally advanced, but is some sort of oligometastatic in which we can have a double of median survival, and we can have also some patient surviving long survival till 3 or 5 years. So these oligometastatic gastric patients are next target for the surgeon. For this reason, in the European chapter of IGCA, we started a study, the OMEC study. This study was conducted by the Dutch colleagues, but all the European colleagues joined the study just to define clearly oligometastatic gastric cancer, because with a clear definition, we can just suggest a good or the right treatment. The problem of the OMIC trial, we reach a consensus about the metastasis. The consensus was one organ with 3 metastases, so 1 extra-regional lymph nodes, liver with 2 bilobar or 3 unilobar metastases, lung 3 unilateral. This was reached in this paper, but some doubts clearly grow up from this OMEC study. First, for example, extra-regional lymph node station were included laterocervical station. Why? Because in the OMEC there was, in my opinion, a mistake, because the definition was for both gastric and esophageal cancer, that are 2 different movies, 2 different films. And maybe a very important thing is missing in the OMEC, the definition of oligometastatic for peritoneal disease. And as you know, half of the patients in stage 4 in gastric cancer are stage 4 due to peritoneal disease. For this reason, we organize as an Italian group together with the European chapter a consensus in Bertinoro about the definition of oligometastatic gastric cancer, adding the peritoneum. What are the results? The results are that statement 7 and 8 is exceptional, excellent agreement. In the statement 7 was the same of OMEC, 3 technical resectable liver metastases in response to chemo. For the lymph nodes, we clearly established that oligometastases are only loco-regional lymph nodes or abdominal lymph nodes, so the para-aortic station, not anymore the supraclavicular lymph node station. And very important is state 9, because with this statement, there was exceptional agreement to define oligometastatic a patient with a PCI score in the peritoneum less than 6 or equals to 6, and in which a positive cytology was converted to negative cytology in response to chemo. So the agreement also was that the surgery for oligometastatic lesion cancer means to perform the surgery for the initial volume of the tumor, not only to the remaining cancer. And after, this is very important, after response to chemo, I don't know if maybe the ctDNA, DNA, the circulating DNA, will help us also in the selection of patient as it's going to happen for colorectal cancer. To finish, just a proposal to add something in the treatment of the peritoneum. There is a very important study that the PI, I am the PI of this very important study, is from Verona, is VER1, is an Italian study that is going to become a European study, and is to add a local treatment, PIPAC, to the treatment of metastatic, the first line metastatic was FOLFOX. We add the PIPAC every 2 FOLFOX just to understand FOLFOX plus Simone or is ongoing. So we have to understand if to add the local regional treatment with PIPAC could improve the result in the treatment of peritoneal carcinomatosis. Thank you very much.
Good afternoon, everybody. My name is Maria Bencivenga. I am from Department of Surgery of Verona University, and today I'm talking about some news and topics in colorectal cancer surgical oncology. I will talk about locally advanced and stage 4 settings mainly. In the surgical field, one of the main news are the increasing evidence on the role of a complete mesocolic excision, especially for right-sided colon cancer. And we had a recent meta-analysis of randomized control trial clearly showing an improved safety and a higher number of resected lymph nodes with the CME, even though we still have few data on the long-term outcomes associated to this procedure when compared with the standard. Moreover, we all know that sometimes this technique is maybe very difficult to be performed and to learn. And that's why we last year had a consensus of experts aiming at clearly defining the anatomical landmark in order to standardize the technique. And in this context, robotic surgery may have a role, may help by reducing the learning curve that is necessary to safely perform this surgical procedure. Another important news in the management of locally advanced colorectal cancer is the possibility to stratify the risk for indication for adjuvant treatment, for adjuvant chemo, based on the ctDNA. That was suggested by the large Galaxy study, and more recently we have results from the Dynamic 2 trial that is focused on the stage 2 resected colorectal cancer. Here, a ctDNA guided arm was compared to a standard of care with regard to indication of adjuvant treatment. And as you can see here, we can observe a fewer rate of patients receiving adjuvant chemotherapy in the ctDNA guided arm when compared to the standard of care. But at the end, the recurrence-free survival in the long term is exactly the same. This means that in the ctDNA guided strategy, we can avoid in some patients with ctDNA negative the toxicity of adjuvant chemo, and maybe some patients in this group are cured with surgery alone. Accordingly, at ASCO GI 2024, we had the results of the bespoke study protocol showing that in the ctDNA negative patients, disease-free survival benefit was not much different whether they received chemotherapy or or not in the adjuvant setting. So very likely this strategy based on the evaluation of minimal residual disease according to the ctDNA after surgery, 4 weeks after surgery, may enter in clinical practice and be help in better treat our patients. For local advanced rectal cancer, we are in the era of totally neoadjuvant treatment, and the two important studies evaluated this approach for treatment of rectal cancer, and these are the Rapido and the Prodige 23. In the Rapido trial, a short course of radiotherapy followed by consolidation chemo was compared to the standard of care. While in the Prodige 23, an induction chemo followed by long course chemoradiotherapy and surgery and adjuvant chemo based on the physician preference was compared to the actual standard of care. This year we had the results that Rapido failed to demonstrate a benefit as a TNT strategy with compare to the standard of care, and this is mainly due to an increased risk of locoregional recurrence, and maybe because of the suboptimal radiotherapy strategy investigated in this trial. On the other hand, the Prodige 23 trial showed an improved 3-year disease-free survival in the experimental arm, a higher rate of PAT-CR, and so suggesting a benefit of TNT when compared to the standard. But again, we don't have a definite answer, and the OPERA trial is a phase 2 trial compared the two TNT strategies between them. On one hand, we had induction chemotherapy followed by chemoradiation. On the other arm, we had chemoradiation followed by consolidation chemo. But of note, in this trial, in both arms, chemoradiation meant long-term chemoradiotherapy. This was different from what we observed in what I've just mentioned in the Rapido trial. Well, the results of these studies is that the two TNT strategies did not much differ between them, with a 5-year disease-free survival that were similar between the two groups. But what is very interesting to observe then is that in the chemoradiation followed by consolidation, we had a longer TME-free survival with higher rate of organ preservation when compared to the induction chemo followed by chemoradiation. We don't have definite answer. We know that starting from now, we should think about TNT approach. But maybe if we need a downstaging, if we need a downsizing of tumor, if we want to optimize the clinical complete response in our patients, we should perform a long course CRT followed by consolidation chemo. On the other hand, if we have patients with a high risk of systemic recurrence, we maybe want to start with induction chemo followed by chemoradiotherapy. Another important change in the clinical practice in 2023 for the rectal locally advanced cases are the need to test MSI biomarker, the MSI status, before starting any treatment, as this study clearly showed that in MSI locally advanced rectal cancer, we can achieve, and 100% of patients achieved clinical complete response and organ preservation after a single agent immunotherapy. We know that the rate of MSI tumor is not that high. It's about from 5 to 10% of cases, but still the results are very impressive and this changed the practice last year, as we definitely need to test the patients for these biomarkers before starting treatments. Surgery did not change a lot in the context of TNT. Of course, we have to perform the same TME that we have always performed, but with regard to extension of lymphadenectomy to the lateral pelvic area, here there's some debate. We can suggest based on the available evidence, that a targeted approach would be better. This means to resect, to extend our nodal dissection to the lateral pelvic area in case of lymph nodes that remain clinically positive enlarged after totally neoadjuvant treatment. For the stage 4 colorectal cancer, we all know that the prognosis of these tumors much improved in the last 20 years, and this is mainly due to the introduction of the novel anti-cancer drugs, and especially of target agents, but also surgeons had a great role, especially in the liver-only metastatic setting, as the surgical resection of these patients, of this liver metastasis, was associated to a great benefit in terms of survival. But which is the best systemic treatment this patient who very well respond to systemic treatment and can be then resected in the metastatic setting. We know that for left-sided metastatic CRC that are KRAS and RAS and BRAF wild type, HER2 negative, and MSS, so in a sort of negative selection. Now the best treatment is chemotherapy plus anti-EGFR treatment, and this for the first time was proven in the prospective setting by the Paradigm trial. So indeed, these are patients that are candidate to intensive chemo plus targeted agents with very high with very good chance to respond to this treatment. And also at ASCO GI 2024 last week, we had news that in MSI high colorectal cancer is the first line. We all know that at the moment we can have a single agent pembrolizumab treatment as first line in MSI CRC, but we got the good news that the combination with the Nivo-Ipi was associated to a very good benefit, improved benefit with compared with the single agent immunotherapy. So probably the combination would be the new standard of care very soon. And also we had evidence that in HER2 positive metastatic colorectal cancer, we can use anti-HER2 target therapy. And why not also for BRAF mutated patients, based on some trials on the pre-treated patients, we got that encorafenib plus cetuximab is a very good option, and we all know that Breakwater trial is ongoing. It is a trial where we all are waiting for that. It is trying to demonstrate that the association between encorafenib and cetuximab could be effective in the first line for these mutated patients. So maybe in the next future also for BRAF mutated cases, we will change our first line strategy. So all these new options, all these very effective treatments are coming for the first line treatment of CRC, and this will definitely impact on a surgeon. On the surgeon activity. We all know that in the metastatic setting from CRC, especially for the liver only, we have three scenarios, the one of initially resectable, the borderline resectable situation, and the initially unresectable cases. Even though we don't have a shared definition and a prospective evaluation of criteria that should be used to define a borderline resectable case, we all know that even if these cases sometimes can be technically resectable, we should start first with a systemic treatment, the first line systemic treatment, because even though we can achieve radical resection, in some of these cases, we will not benefit our patients due to oncological borderline resectability. So we have to start with the first line treatment and then move to operate the patients. On the other hand, no matter of choice, for initially unresectable cases, we need to use all the strategies, effective strategies that are coming. The issue in the borderline resectable patients is which is the best systemic treatment to be used. Until some months ago, we had the suggestion not to use target therapy in order to avoid the issue of vanishing metastasis. But with all these new options coming up from the patients right now, it's very difficult to establish which is the best treatment strategy, and maybe it will depend mainly on how borderline is our patient. And the best way, we don't have definite answer, the best way to treat these cases will be to let the medical and surgical oncologists communicate very closer and closer in order to establish the optimal systemic treatment, the timing of restaging, the timing of surgery, and to make the best treatment for every single case. In the initially unresectable scenarios, we need to use all and the most effective treatments that we have, as shown by the Cairo 5, even for the right-sided tumor, where the strategy, the chemotherapeutic strategy was enhanced with the FOLFIRI plus bevacizumab in order to improve the response, the objective response rate, and with the hope to operate these patients and to improve their prognosis. I thank you for your attention, and I'm available for further questions.
Hi, everyone. In the following slides, I will present the pivotal findings and practice changes in surgical oncology throughout 2023, focusing on pancreatic cancer surgery. I am Salvatore Paiella. I am Associate Professor of Surgery. I work at the Pancreatic Surgery Unit of the Pancreas Institute of the University of Verona in Italy. This is the agenda layout. I will talk about pancreatic cancer research at large, about resectable pancreatic cancer, borderline resectable and locally advanced pancreatic cancer, and metastatic pancreatic cancer with a surgical point of view. In 2023, for the first time, a vaccine against pancreatic cancer was developed, and the study was published in Nature. 15 patients received a combination of mRNA neoantigen vaccine followed by immunotherapy and chemotherapy after surgery. Patients who exhibited a vaccine-induced T-cell expansion were considered responders to the vaccine and performed much better than non-responders. This is probably the most extreme expression of personalized therapy and pioneering use of vaccine in the clinical context of pancreatic cancer. This study comes from China, is in the field of pancreatic cancer early detection, and it deals with an implementation of a deep learning algorithm into radiology, specifically into a non-contrast CT scan. The PANDA algorithm was able to identify the pancreatic lesion with an area under the curve approximating to 1 and incredibly high levels of specificity and sensitivity for lesion detection. This manuscript is in the field of how we can diagnose pancreatic cancer early, starting also from a non-contrast CT scan, probably in high-risk individuals, such as those evaluated in this manuscript coming from the Netherlands, where CDKN2A patients were submitted to surveillance, and the cancers identified during surveillance were compared with 1 to 5 matching cohort, matched cohort of pancreatic cancer identified outside surveillance. The authors clearly present encouraging results in terms of diagnosis anticipation, resection rate at diagnosis, and survival results. This study comes from the Netherlands and evaluates the impact of complications after resection of pancreatic cancer on disease recurrence and survival. The authors claim that the negative impact on survival of the postoperative complicated course is mediated by a failure to access adjuvant chemotherapy. Finally, this study comes from the US and focuses on patients older than 74 years receiving neoadjuvant therapy and surgery for pancreatic ductal adenocarcinoma. Many of the messages are delivered. Among them, I want to mention a few. First, fewer older patients were able to complete the intended neoadjuvant FOLFIRINOX cycles compared to younger patients. However, older patients were just as likely to undergo surgical exploration and surgical resection as younger. Older patients did not experience a worse postoperative course. However, their overall survival was much worse than younger patients. Finally, older patients who underwent neoadjuvant therapy followed by surgery performed better than upfront the patient who received upfront resection. When it comes to resectable pancreatic cancer, this meta-analysis at the beginning of the year of 6 randomized controlled trials involving resectable pancreatic cancer patients and administering different chemotherapy regimens presented that data about overall survival and disease-free survival that was not in favor of one approach over the other. However, the relative risk of an R0 resection was slightly greater in the neoadjuvant therapy group. In 2023, the preliminary results and very recently the full results of the NORPAC-2-1 trial were published. It is a multicenter randomized phase 2 trial, including patients suffering from resectable pancreatic head cancer, randomized to receive neoadjuvant FOLFIRINOX versus upfront surgery. Considering 140 patients and consider a primary endpoint according to an intention to treat analysis, the proportion of patients alive at 18 months was 73% for the upfront surgery group versus 60% for in the neoadjuvant FOLFIRINOX group, and this was statistically significant. The secondary endpoints, according to an intention to treat analysis, instead were similar, at least not statistically significant among the two groups. This study comes from the Netherlands as a spin-off of the PREOPANC trial And the authors, for the first time, demonstrated that the females have a more favorable prognosis than male when it comes to patients treated with neoadjuvant chemoradiotherapy, presenting a 5-year overall survival rate of 43% versus 22%, and claiming that this difference comes from a peculiar tumor microenvironment as demonstrated by transcriptomic and spatial proteomic analysis. Finally, the results of the diploma trial were published. It is an international randomized non-inferiority trial comparing minimal invasive versus open distal pancreatectomy for resectable pancreatic cancer. The number of patients enrolled was approximately 250, and the authors clearly presented results in favor of the concept of non-inferiority of the minimal invasive distal pancreatectomy when it comes both to surgical postoperative outcome metrics and oncological metrics. Moving toward the borderline resectable locally advanced pancreatic cancer, this manuscript was published in 2023. It is a position paper by the study group at the joint meeting of the International Association of Pancreatology and Japan Pancreas Society held in 2022. The experts conveyed a clear message about the importance of tumor biology and not only about surgical technique in locally advanced pancreatic cancer, underlining the importance of patient selection based also on the levels of CA99. This study comes from the European and African Hepato-Biliary Association. About 250 patients were resected, were included. They were borderline resectable and locally advanced pancreatic cancer patients. And apart from the interesting numbers of zero resection and survival numbers and patients receiving adjuvant chemotherapy, the manuscript did not provide any statistically significant number of appropriate and effective preoperative chemotherapy cycles. And looking at these curves, it becomes it is appropriate to say that the number of cycles between 5 and 8 is the one to follow, and there is no need to go over 8 cycles, and it is not appropriate to perform less than 5 cycles. This study comes from the Netherlands. It is called the UltraPanc study. It is a prospective multicenter study enrolling 85 patients in whom a preoperative suspicion of vascular involvement was present at the cross-sectional imaging, and it was designed to investigate whether intraoperative and ultrasound changed the resectability status. It occurred in 38% of cases, in detail in 42% of locally advanced pancreatic cancer and 69% of borderline resectable pancreatic cancer that were ultimately downstaged. And additionally, when there was a presumed SMA involvement, the 71% of patients had no SMA involvement at the intraoperative ultrasound. And of this group of patients, those who received surgery had an R0 resection at the SMA margin at final pathology. In 2020-23, the results of the ESPAC-5 trial were published. The ESPAC-5 was a 4-arm multicenter, 16 centers in the UK and in Germany, randomized phase 2 trial, comparing immediate surgery with short course of neoadjuvant gemcitabine plus capecitabine or FOLFIRINOX or chemoradiotherapy in patients with borderline resectable pancreatic cancer. Apart from the very interesting results that can be read going deep into the manuscript, these curves present the main 2 messages of the study, namely that immediate surgery should not be performed in borderline resectable pancreatic cancer patients, and that among the non-surgical treatments, patients who received FOLFIRINOX had a more favorable prognostic outlook. One of the most relevant aspects to evaluate in the management of pancreatic cancer patients, the borderline and the locally advanced pancreatic cancer patients, is the CA19-9. In detail, the CA19-9 response after the therapy. This study comes from Italy, is led by Verona, and presented the experience of 2 centers and 350 patients suffering from resectable and non-resectable disease. Important data are provided about the interaction between CA19-9, the dynamics of CA19-9 during neoadjuvant therapy, and the interaction with the tumor sites. It was found that per-treatment tumor sites less than 20 millimeter, a normal post-treatment CA19-9 and a delta CA19-9 of more than 50% were all associated with longer recurrence-free survival. The topic of the changes of CA19-9 was also faced by this study coming from the Netherlands. The authors found that the minimum CA19-9 response demonstrating a clinically significant median overall survival difference was seen when the CA19-9 decrease was greater than 40%, with an optimal cutoff of 60%. And this cutoff of 60% of decrease was, among the others, one of the factors independently associated with prolonged overall survival. When it comes to the metastatic setting, the role of surgery has been only marginal historically. I selected this manuscript. It is a systematic review of 13 studies and 409 patients. It includes patients suffering from oligometastatic disease. However, there wasn't uniformity among the studies with regard to the concept of oligometastasis. It can be seen that the majority of cases received surgery besides not specified, and that among the non-surgical treatments, RFA, radiotherapy, and radioembolization were the most used one. Looking at the lines presenting the oncological results, the results are very encouraging. However, especially if we consider those of the cohorts of metastatic pancreatic cancer patients treated only with chemotherapy. However, it must be remembered that the cases considered were 409, namely only a minority of the total. They were super selected patients. Nevertheless, surgery in metastatic disease should not be refused on purpose. Instead, it can be sometimes be considered in the context of a multidisciplinary decision and appropriately shared with the patient. This is the last slide. I thank you for your attention. I thank Dr. Roberto Montorsi for his supporting in preparing these slides. Bye.
Hello to everybody. First of all, let me introduce myself. I am Simone Conci, an academic surgeon at the Department of Surgical Sciences, Dentistry, Gynecology, and Pediatrics of the University of Verona. My field of interest is the hepatobiliary surgery, with a focus on surgical oncology and minimally invasive approaches. I have nothing to disclose. If I want to title the 2023 scientific efforts in the field of hepatobiliary surgical oncology, it could be integration between surgery and oncology. Compared to other cancers, such as breast or colon, the current multimodal treatment protocols for hepatobiliary cancer, which combine surgery and systemic therapy, are still being debated and are not able to improve survival as we would like. However, I will show you some encouraging data on feasibility, results, and the possibility of integration. I choose 3 main topics in my speech. I will talk of cholangiocarcinoma, hepatocellular carcinoma, and colorectal liver mets. The biliary tract cancers are a heterogeneous group of malignancies, including gallbladder cancers, intrahepatic and extrahepatic cholangiocarcinoma with a very dismal prognosis. Unfortunately, they present with an advanced stage at the time of the diagnosis in about 60% of the cases, Surgical resection remain the only treatment potentially curative, but is an option only in approximately 40% of the patient, and it is curative in only 20 to 30% due to a high disease recurrence rate. The landmark BILCAP trial established a standard option for adjuvant chemotherapy with a monotherapy capecitabine, despite no statistically significant differences in overall survival compared with observation alone in an intention to treat analysis. No neoadjuvant strategy are currently available, but there are some light in this darkness. The first paper that I would like to talk about is this one, the NeoGAP trial, a single-arm phase 2 study of the use of gemcitabine, cisplatin, and nab-paclitaxel in a neoadjuvant setting in patients with resectable but a high-risk intrahepatic cholangiocarcinoma. The trial was conducted in 4 worldwide renowned U.S. cancer centers, the Winship Cancer Institute of Atlanta, the MD Anderson Cancer Center of Houston, the Mayo Clinic, and the Virginia Mason Medical Center of Seattle, and published on Annals of Surgical Oncology in 2023. In the slide are reported the inclusion criteria. Patient with resectable intrahepatic cholangiocarcinoma, but with a single lesion more than 5 centimeters, or multiple nodules in the same lobe, or with vascular invasion are considered high-risk patients. Moreover, also patients with suspicious regional lymph nodes at the preoperative imaging are included, but patients with extrahepatic disease, impaired performance status, or global function are excluded. The study included 30 patients from 2018 and 2021, and here are shown the study protocol. After the enrollment, patient underwent 4 cycles of chemotherapy with administration of nab-paclitaxel, cisplatin, and gemcitabine on day 1, 8, and 21. After that, they are restaged and evaluated for surgical resection. The primary endpoint was feasibility. Then other endpoints were tolerability, radiologic response, recurrence-free survival, and overall survival. 22 out of 30 patients completed the protocol and underwent radical surgery with a feasibility rate of 73%. The tolerability and toxicity were quite good, with a severe adverse event rate of 33%, mainly due to neutropenia and diarrhea. The authors reported a disease control at the end of the chemotherapy period of 90%, with a radiologic progression disease in 10%. From surgical point of view, R0 resection was achieved in 73% of the patients, and the rate of metastatic lymph nodes was 36%. The data on long-term outcomes are influenced by the short median follow-up period of only 16 months. However, the median recurrence-free survival was 7 months. The study has several limits. It is a single-arm phase 2 study. No standard adjuvant chemotherapy was recommended. There are neither a central revision of pathological specimen nor molecular characterization, and also the results are suboptimal since 1/3 of the patients did not complete the protocol. However, give us hope regarding the feasibility and tolerance of neoadjuvant therapy in patients with intrahepatic cholangiocarcinoma without adversely impact postoperative course. Hepatocellular carcinoma account for approximately 80% of primary liver cancer and is the 4th leading cause of cancer-related death worldwide. Surgical resection or local ablation are cornerstone of the curative intent treatment for early-stage HCC. However, rates of postoperative recurrence following resection or ablation are reported to exceed 70% within 5 years. To date, there is no standard of care adjuvant treatment option for patients with HCC. However, recently, atezolizumab, an anti-programmed death ligand 1, combined with bevacizumab, an antivascular endothelial growth factor, became the first-line standard of care for unresectable hepatocellular carcinoma, based on the result of the IMbrave 150 study. which showed superior overall survival, progression-free survival, and objective response rates with atezolizumab plus bevacizumab compared with sorafenib. This data provide a rationale for exploring this combination regimen in an early treatment setting, and the first step toward a real multimodal and integrated treatment strategy. According to this background, the result of the IMbrave 050 trial are welcomed. The study is a phase 3 randomized controlled trial that compare atezo and beva versus active surveillance in patients with resected or ablated high-risk ACC. The panel showed the inclusion criteria in case of resection and ablation. In summary, up to 3 resected ACC nodule with largest more than 5 centimeters, regardless vascular invasion or poor tumor differentiation, G3 or 4, up to 3 nodules with the largest equal or less than 5 centimeters but with vascular invasion, and 4 or more nodules with the largest equal or less than 5 centimeters, and for ablated patient, single nodule between 2 and 5 centimeters or up to 4 nodules but less than 5 centimeters. Over 134 centers were involved in the study. 668 patients were enrolled and then randomized 1-to-1 to the treatment or surveillance arm. In case of recurrence during surveillance, the patient was shifted to systemic therapy. Primary endpoint was recurrence-free survival. Here you can see the flow chart of the study. 334 patients for each arm were included in the intention to treat analysis. The recurrence-free survival curves separated early and remain clearly separated up to the median follow-up of 17.4 months, after which the curves began to come together, with a 12-month recurrence-free survival rate of 79% in the atezo-beva arm and 68% in the surveillance arm. Moreover, looking at the subgroup analysis, there are some characteristics in which the benefit of treatment seems to be less evident. For example, in the HECOG-1 patient, in patients with nodule less than 5 centimeters, and in patients submitted to TACE. Of course, the study has some limitation: the open label design, the short follow-up period of inclusion, but the published papers represent an interim analysis, and further data and results will be published in the future. And once again, no molecular characterization have been taken into account, but give us some interesting results, in particular, the acceptable toxicity of the chemotherapy regimen and a 10% of increase of recurrent-free survival at 12 months in the treatment arms. And now the last part of my talk will be on colorectal liver mets. Hepatic resection is the gold standard for treatment of colorectal liver metastasis with curative intent, with reported median 5 years survival of around 40%. In the last years, the effort of the surgical community were focused on demonstrating the values of parenchyma sparing strategy and minimally invasive approach. The paper that I will show you has been very debated between hepatobiliary surgeons. In fact, the study aims to compare the results of microwave ablation with surgery in the setting of resectable colorectal liver mets. This is an European multi-institutional study involving the University of Bern, Groningen, the Karolinska Institute. Here you can see the inclusion criteria: up to 5 resectable nodules less than 3 centimeters, eligible for both resection or CT stereotactic microwave ablation, and below are reported the exclusion criteria. The study design includes a study groups submitted to microwave ablation and a control group with the same clinical characteristics extracted from a prospectively maintained nationwide Swedish database, Reliv database. The two populations were subsequently matched with a propensity score. Finally, 98 patients were included in the study group and 158 in the control group. The primary endpoint was overall survival at 3 years. The success rate after first procedure of microwave ablation was 96% and 99% after 2 treatments. The local tumor progression rate at 12 months was 17%, with 2% of severe morbidity. 1 patient drained for an pneumothorax, and unfortunately, 1 patient died for the sequelae of a liver abscess and a concomitant gastrointestinal fistula. However, the survival curves of the hepatic resection and microwave ablation were very close. So, with the limits of this type of study, that is not a randomized control trial, the authors reported data that support the non-inferiority of microwave ablation compared with surgery in small, less than 3 centimeters, colorectal liver mass, and this could lead to a less invasive attitude for this subset of patients. So, in conclusion, what awaits us in the future? Probably ongoing and new randomized control trial that investigates the timing and integration between surgery and systemic therapy could improve the feasibility, safety, and the results in the treatment of hepatobiliary malignancies. Of course, the molecular characterization and artificial intelligence should be included and will be included in the treatment flow charts. And minimally invasive treatments such as laparoscopy, robot-assisted surgery, but also ablation techniques will be the weapons in the toolkit of the new era hepatobiliary surgeons. Thank you for your attention.